Right. And so you give it today, you're going to pass it on. So you have to clap yourself. That's the very first thing women have to do. Clap themselves. Tell people about the good and great things that you're doing. Keep speaking truth to power, and it will be received. Now, if you have 49,000 people coming to the health center in 1 year, and I told you 65% of them are women, how come for cancer screening we only served 10,000? Now let me keep going. Out of 49,000 people, do the math, 65%. I was going to say 70 because you could take a 30% from that and make it easy. But I'm going to use 65. 65% of the 49,000 patients are women. Only 1,500 women received breast cancer screening last year. I'm going to make that sink in. How is it out of 49,000, we got 10,000 for cervical cancer screening, which is great, but not good enough. Only 1,500 women were screened for breast cancer. We're falling short, very short. And while NCHC has changed its method of how we provide patient care, standardized care means when you come into the health center, we're going to give you everything. Everything is in the building. Dental, medical, registered dietitian, behavioral health. We've got everything in the building. And once you come in, and we hate to say it, we do apologize for wait time. And we will apologize for wait time because your time is precious to us, right? But our critical problem is that when people come to the health center, they have so much clinical problems, medical problems, that when they get into the doctor's office and they start talking, they can't stop. And so while you're in the waiting room, you want people to rush through because you're waiting for your turn and you want it to be fast. But when you get in there and you start talking about all these ailments, then it means people in the back. But we don't think about it like that. And so I tell people all the time that an FQHC, which is who we are, federally qualified health centers, we're not a fast food McDonald's. So why would you come to healthcare and want us to treat you like fast food McDonald's? And then when you get inside there to begin to connect to care with the provider, you want your time. So we do apologize for wait time, but we also have to be mindful to change our attitude about coming for healthcare. Yes, you got to get back to work because they're going to fire you. Hey. Yes, you got to get home because it's 3 o'clock and your child is coming off the bus and you don't have anybody to take care of the child. And we do understand this, but you also cannot add to your stress that when you come to the health center and you want quality care, that you have to wait a little bit. You complain, your blood pressure go high. Stresses you out. And then when you get in to see the provider, you do want your quality time. The insurance company says it's 15 minutes, right? You all know this. We're going to blame it on the health, the payers, right? 15 minutes, 30 minutes for a physical. But when you get into that door and you start to talk to that provider, there's so much stuff you got to tell the provider. Not only that, you have to offload your mental stress. It is good for you to come to see the provider. You may think you're only coming for medical condition, but you're also coming for mental health too, because when you get inside there and you begin to express your concerns about what you think is going on with your body, it is a relief because you understand that you're talking to somebody who is now going to help you to deal with all of that. So I'm saying this to say 49,000 people we served, 10,000 cervical cancer screening, 1,500 for breast cancer screening. And it's not enough. NCHC never tells a patient, we can't see you today. We hire culturally sensitive staff to take care of our patients. And especially our nurses and our doctors, they know that no matter who comes through that door, we never turn you away. And then we try to encourage, if you don't have an appointment, but we're going to see you, you just have to wait a little bit. Why are you going to stress out yourself? When you don't have an appointment, yes, we're going to see you. Just hold on. We're going to fit you in. But then you're going to stress out about the fact that you've been waiting for 1 hour and you can't get in. We are trying because we don't want you to turn away. What I'm trying to say here is this, that the message that we all need to say in this room and to share with everyone is that your health care is high priority. You need it for the creation of care and the sustaining of life, creating life and sustaining life. So therefore, we all have to think about how we take care of our bodies and how we tell others to take care of themselves. NCHC has 350 employees across Newark, East Orange, Irvington, and surrounding communities. How many do you have at Newark? 30,000. See, they're amazing, aren't they? That's the other FQHC that is in this community. But they serve the entire city of Newark, and you do have surrounding people coming. Is it enough? Is it enough? No, it's not. And so we all know it's not enough. But what is critical is that you must take the time to make an appointment. Take the time. We are open on Saturday and Sunday and 4 to 7 p.m. Between 4 to 7 p.m. in the health center is a ghost town. Between 8:30 and 12 is a mad rush because everybody wants to come between 8 and 12. 4 p.m. to 7 p.m., the providers sitting, just sitting. When you look inside the health center, you're like, oh my God, what are we going to do here? Empty. Saturday is busy up to 1 o'clock. Between 1 o'clock and 5 o'clock, it's a ghost town. Come on now. Sunday, we incentivize our providers, so we pay time and a half, don't tell anybody, to encourage the providers to come on a Sunday. And between 9 o'clock and 1 o'clock, the place is a ghost town. The message we send out to the community is that we're open extended hours. We're telling you, come on in. But we don't. So I am not saying that the onus is not on us, the provider of healthcare. I am saying the onus also is on each and every one of you. Take the time, make the time, because you can access health care. Bring your child with you on a Sunday. We have no problem with that. Do you get the point? If you have no daycare, bring the child with you on a Saturday. We have no problem with that. Find the time, make the time. No, we are the giver of life, and so we serve or we do deliveries. 2,100 babies are born, right? Last year, it was so exciting. We're required by FTCA to do emergency in OBGYN. So every year we do the emergency. What happens if something goes wrong and delivery happens in the health center? It never happened until last year. It was so exciting. We're still just having a joy about it. Deliveries is done at the hospital. We take care of you for 9 months and you go to the hospital and have a lovely delivery. Delivery happened right there in the health center. And our staff was just popping, just like the baby. Popped out, very nice and healthy. It couldn't wait. We did that. And so we're proud of what we do as an FQHC for prenatal care. And so 2,100 babies were born last year. We try to give free pregnancy tests for everybody that comes in. Don't take offense if you have childbearing age and our provider says, we offer free pregnancy testing. Some people take offense. Don't take offense. Because what we're trying to do is to have early entry into prenatal care, right? Sometimes people get offended because, they don't like to be asked those questions, right? And especially if you're like me, you're extra large. And somebody asks you that, you're going to get upset. Thinking that do I look like I'm pregnant and I'm not? I just, have broad hips. Don't take offense. Tell the women that don't take offense, and your young girls, tell them it's quite all right when you come into the exam room, you have childbearing age, and they ask you about pregnancy test, right? But what we're trying to do is to get you into early entry to prenatal care. We are doing very well at it because we offer free pregnancy testing right there. And as soon as you're positive, your first visit for prenatal care starts on the very day. And so we're about 90-something% in the number of women who come in for early entry into care. So we can get a round of applause for that. Yes, yes, yes. It's working. We try our best to have healthy prenatal care for delivery, right? And so NCHC keeps a higher standard than the national standard. You all know that by now. What it means is that the standard for low birth weight babies is 6% by the national standard. 6% is okay. We say 3% is what's okay for us. And it's not okay because we want all our babies to be born healthy and happy moms. Over the last 4 years, we have risen from 3%, 4%, 5%, and the previous year, 2024, we were at 6% that the number of children are born with low birth weight. Do you see what's happening here? So we've introduced a lot of things to help the woman, and we'll talk about it later today in the clinical section. But the critical piece is that with all the efforts that we made, and Dr. Mahdi, our Chief Medical Officer, is going to go into that in the afternoon, for the first time in 5 years, the number of children with low birth weight dropped to 4%. So what we're doing is good. So in the afternoon, don't leave. I want you to hear from the Chief Medical Officer, and you're going to give her a round of applause for that, all right? I'm telling you ahead of time to give her a clap for that. But here's the problem. If we deliver 2,100, and very rarely they're twins, right? So approximately 2,000 women gave birth. If we have 500 that come back for postpartum, we have a lot. Are you getting the math? So the very women who deliver the babies are not coming back for postpartum. And this is not for the want of the provider and the nurses telling them how critical it is. Am I making sense? You see where I'm going here? See where I'm going? If we are the giver of life and sustenance of life, then there's certain things that we got to do without anybody telling you. Access to care is hard and difficult, but it can happen. It may take a little bit longer, but it's better you stick to it and do it, and it takes longer than doing it none at all. So today is a great day for us, isn't it? Because today we're going to talk about these things. We're going to hear from the political side, all our elected officials, to hear what they're doing to increase access, to make it more affordable, so that we can participate. But we're going to talk in the afternoon about the clinical side, about what is involved in medicine, dentistry, behavioral health. But the critical piece is what we just talked about a while ago. You have to make that step. You have to decide. Just like how you take the time to care for your child and we do anything possible because they get that child to the pediatrician after it's born. Get about themselves. How are we going to stop forgetting about ourselves? And it's not selfish. A lot of times we think that we're selfish if we think about ourselves. But it's not selfish because the data is showing that we are forgetting about ourselves and we are becoming less healthy. Then how are we going to be good givers of life? And how are we going to sustain life if we ourselves are not sustainable? Think about it. So today we have a number of remarks from our elected officials. They can't be here today. As you know, a lot of things is going on in Washington. You all know that, right? They can't leave. And so what we're going to do is that we have some messages. We have some messages, some videos, right? We're going to show. They ask, could they get their message to you because they can't leave Washington. And do you blame them? No. Is that the reason why you elected them? For them to be in Washington and to stay down there till they get it right? Right? Do you all agree? Okay, so let us hear from our elected officials. Thank you.
Hi, I'm Senator Cory Booker, and I'm truly honored to be a part of the Women's Health Symposium today, bringing together leaders, providers, and community members who are committed to improving health outcomes for women. Thank you to the Newark Community Health Center for the incredible work you do every day to break down barriers to care for women and expand access to essential health services. And congratulations for 40 years of outstanding service to the Newark community, my home community. For 4 decades, I've witnessed it. You have been a trusted source of compassionate, high-quality care that has made a lasting difference in the lives of countless people and families. Too often, women, and especially Black and Latino women, face disparities in care, including higher rates of maternal mortality, delayed diagnoses, and limited access to preventative services. This is why my priority in Washington as your senator is to elevate and work to expand access to women's health and reduce health disparities. I am so proud to be reintroducing my bill, the Black Maternal Health Momnibus Act, on Mother's Day this year. This is a comprehensive package of bills that aims to address the maternal mortality crisis by investing in social determinants of health, such as housing, nutrition, and transportation. This bill will be transformative for women across the country and help end preventable maternal deaths. You know we can do this together. I also introduced the Access to Birth Control Act because women should never be denied or intimidated when seeking contraception. My Right to IVF Act, which I will be reintroducing again this year, will establish a federal right to in vitro fertilization and other assisted reproductive technologies. I am committed, driven to strengthen women's health outcomes, lowering costs, protecting care, and ensuring that women get the service they need without delay. Together, our work shines a light on the disparities that exist, closes gaps in care, and makes sure every woman, no matter what your zip code is, has the opportunity to live a healthy life. I will continue to fight for critical investments and common sense policies that put women's health on the forefront of all the work that we are doing in America. We have got to center women and let women lead. I'm grateful to have all of you in this work with me. I have a lot of faith that we can overcome the obstacles and achieve great victories for women's health. Thank you.
Good morning to Newark Community Health Centers Incorporated, and congratulations on your 10th annual Women's Day Symposium. I want to thank President Dr. Pamela Clark for the opportunity to celebrate this milestone with you all. Dr. Clark's leadership and commitment has led to women and families across Newark getting access to quality and compassionate health care, and I am so thankful for her work. For nearly 40 years, Newark Community Health Centers has stood in the gap for communities too often overlooked and underserved. And in a city like Newark, where so many families are balancing work and the demands of everyday life, having trusted healthcare providers rooted in the community matters more than anything. That's why I love this organization. Whether it's medical screenings, OB/GYN services, or pregnancy support, Newark Community Health Centers has always been there for New Jersey's 10th Congressional District. And I think one of the most powerful things about the work being done here is that it meets women where they are. Because far too often, women put themselves last. We make the appointments for everyone else. We carry our families, our workplaces, and our communities on our backs. We push through exhaustion and tell ourselves we'll get around to prioritizing our health later. But preventive care and early screenings are the resources that save lives. And organizations like Newark Community Health Centers are saving lives by making those resources accessible and affordable for women in our community. That mission is especially important at a time when health disparities among Black and brown women continue to grow. That is why I remain committed in Congress to protecting and expanding access to health care for women and families across New Jersey's 10th. Because quality health care should never depend on your zip code. As I fight to expand healthcare access on the Hill, I'm proud to stand alongside organizations like Newark Community Health Centers that are doing real work every single day to eliminate disparities and help people live healthier and stronger lives. So let's today be a celebration of women and caregivers, healthcare workers, advocates, and community leaders who make our lives so much better. But also let today be a reminder to take care of ourselves too, to schedule the screening, to make the appointment, to check in with the women we love, and to continue building a community where every woman feels supported, seen, and cared for. I'm proud to celebrate 10 years of this symposium's success, and I'm excited to see you prosper in the next 10. Thank you.
Through long-standing service and dedication, best wishes for continued success as you carry forward your mission of compassionate, community-centered care. Presented on May 14th, 2026, signed by our Congresswoman, LaMonica McIver.
Awesome, awesome. Thank you so very much. Yes.
While I'm here before the panel starts, they said you weren't honoring anyone. But there's no way you can do something 10 years. Y'all not saying nothing. That means clap.
I like that. Yes. Thank you.
That's getting your cardio going,
Yes.
helping you out here. 10th Annual Women's Health Symposium and 40 years of service. Some people can't last 40 days, 40 months. So we will be celebrating on the 40th anniversary. But the legislative body of the city of Newark wanted to present our dear Pamela Clark and this organization, Newark Community Health Centers Incorporated, to mark this in our city. Does anybody know what city they're sitting in right now? Only 3 people know. What city are we in? Can I hear you again? Thank you so very much. As we're at 54 Halsey Street in the city of Newark, New Jersey, we wanted to make sure that Councilman Council, myself, and the legislative body present something that's going down in the history of the city of Newark.
Again, to the service of Newark Community Health Centers, Inc., this 10th Annual Women's Health Symposium and 40 years of service, for always landing on the line and putting on the line for the health, the welfare of our citizens in the city of Newark. We are always grateful and thankful for each and every work that you do, as well as all of the providers that are here today to recognize that health, mental health, physical health, as well as spiritual health is important to allowing us to survive in these annals of this world. So on behalf of the city of Newark, the Newark Municipal Council, we want to give this commending resolution to the Newark Community Health Centers, Inc. for celebrating this 10th Annual Women's Health Symposium and 40 years of service to the great city of Newark. We, the members of the Newark Municipal Council, want to take this opportunity to congratulate the Newark Community Health Centers, Inc. during its annual 10th Annual Women's Health Symposium and 40 years of service, this governing body honors and applauds and appreciates you from the bottom of my heart, from our council president, C. Lawrence Crump, our councilwoman of this ward, Amina Bay, myself, Patrick O. councilman in the South Ward, Carlos M. Gonzalez, Dupre L. Kelly, Luis Quintana, Aníbal Ramos, Luis Scott Roundtree, and Michael Silva. We want to thank, commend, and lift up the work of community healthcare centers. God bless you, and heaven come out upon you is our prayer for you.
Now, let me say this. We do a lot of homegoing celebrations. We can take the time to celebrate and honor someone who has been on the wall for women's health, your health, children's health, everyone's health. And since we're in the city of Newark, New Jersey, I'm taking the administrative privilege to also represent our mayor. I see OVP here. I see all of these other organizations that are here. But the mayor governs the city. He's just been reelected. He did not want to not take the opportunity to congratulate 10 years of service and commitment. We'll be back in October, but somebody say, but today. We're presenting to our Dr. Pamela Clark and all of her team at Newark Community Health Center Incorporated on their 10th annual. We don't know what tomorrow brings. So on the way to the 40th, we're celebrating it because we're in the womb right now. But in October, it was born. So as the mayor of the city of Newark, it is my pleasure, he states, to honor and congratulate you as we celebrate the 10th annual Women's Health Symposium. The mayor says, I applaud you, Dr. Clark, and the Newark Community Health Center for your diligence and devotion on every level. He says, we're also proud to acknowledge you for the many contributions that you have already made regarding our health and moving forward, and will continue to make in the city of Newark, which will touch many in our county, our state, and God knows our country, and for the strong foundation of ethical values that you are building and will continue to build on this journey. The mayor says, I know you will continue to be an inspiration to us all, and that your greatest days are in front of you. He says, may God continue to keep the gift that you are and will continue to be for humanity, for health's sake. Once again, congratulations, and may this day be a most memorable one. Sincerely, Raz J. Baraka, Mayor. How to hold it. You open that because that's from Congresswoman. You open this. Yes. It's a how to hold it 101 type thing. Right? Here we go. And then do it like that. Yes. Here we go. And then you hold it up like that. Put your hand on the bottom so it don't fall. Here we go.
I learned from the master.
All right. It's fine. One more. Everybody got an employee. Congratulations. There's one more. Uh-oh. Thank you all. Thank you. Put your hands together. Celebrate.
Wow. Wow. Eh, yes, I know, I know. I am shocked and humbled. Yes, yes. And the staff also. And yes, thank you so much. And didn't I just say that we must always shout out whatever it is that we think we need to talk about and clap ourselves? Yes. So a physician once said, physician, heal thyself. So therefore, if I'm telling you that you must champion your own cause and you must be proud of what you do and say it out loud, then I guess, yeah. Okay. All right. And so at this time, it's just absolutely wonderful. Give me a moment because it's just so wonderful. In finding creator of life, sustaining life is moments like these that make you realize that you also have to do the right thing for yourself. So give me a moment because I have not spent time to even think about it. But I will say this, that NCHC is grateful for many things. One, we're grateful to the elected officials who take the time to listen to what we need and to go fight the cause for us to achieve it. So we want to say thank you. We want to say thank you to our partners. And at this time, we don't wait until the end of the service to say thank you. I want to say thank you to all the sponsors here and for those who couldn't make it, but they're still sponsored. And you'll see the names around, and you're going to see them over here. Could you just look to the, is that to the right or the left? That side. And could we just say thank you and have a round of applause for all of our sponsors and donors that are here today. Healthcare Foundation of New Jersey did an amazing job. They covered most of the bill, and we're truly grateful to them. Of course, we have RWJ Barnabas Health System. We couldn't function without them because all of our patients go through there whenever there's a need. We don't want them to be there all the time, but if they have to go to RWJ, that's the best place for them to go for care. We want to thank LabCorp, Henry Schein. Are you over there? You're quiet. Where are they? Oh, yes. Columbia Bank, and I'll talk about that in a minute. Horizon Blue Cross Blue Shields, Newark Alliance, the partnership. Why are you so quiet? You need to champion your cause and clap. Go Staffing, PNC Bank, and Best Care College. But we thank everybody for the partnership in helping us to be a success. Last but not least, we need to thank the staff. NCHC hires culturally sensitive people to care for our patients. And I think they're doing an amazing job. And they go beyond their job because the people who organize this is not in their job description, is it? It says other duties as assigned. Hello. Other duties as assigned. You like that sentence in your job description? Well, the majority of our staff does other duties as assigned. So can we just give a round of applause to the people who organize for the staff here today? We also want to say thank you to the New Jersey Maternal and Infant Health Innovative Authority. They're an amazing team of people who not just provide watchful oversight to women's health in this community, but also in ensuring that policies and procedures are created or are modified to ensure quality care. And so without further ado, do I see Miss Etta here? Yes? Could you come forward? Yes, give her a round of applause. She's doing an amazing job. No, I was told don't lean on the podium. Okay. So I'm telling you here, we don't have any workers comp today. Don't lean on the podium. There you go.
Thank you so much. Good morning. It's still morning, right? I think it is. Thank you so much, Dr. Clark, and congratulations on all you do here, and just allowing me to provide brief remarks before we get the show going. On behalf of my president and CEO, Lisa Sari, with the New Jersey Maternal and Infant Health Innovation Authority, we're just so honored to be here to join the 10th annual Women's Health Symposium and to really celebrate the great work and services of Newark Community Health Centers, centers that I know personally have supported families like mine in the city of Newark, having grown up in the city right in my own backyard. So excited to be here. Let's be clear, family health and women's health are deeply connected. When we have access to preventative care, trusted providers, flexible services, and a strong support system, the entire community benefits. Families are stronger, our children are healthier. Nearly 2 years ago, New Jersey established the authority, the first authority in the nation, dedicated exclusively to maternal and infant health. MIA was created with a clear mission to improve maternal and infant health outcomes, address long-standing disparities that you've heard earlier today, and build systems that ensure every family has access to the care, support, and resources they need to thrive. This mission is reflected in gatherings like today's symposium. This year's event theme of Rested and Radiant is really a call to action to create systems of care that give women the agency to thrive in work, but most importantly, to thrive in their own rest and in their own care. Women should not have to push through exhaustion or delay preventative care or navigate systems that were designed around realities. They should be, never designed around the realities of our lives. We deserve health care that is accessible, coordinated, compassionate, and responsive to the many responsibilities that we take on. And so at MIA, we really are excited and focused in building these partnerships across healthcare, government, academia, community-based organizations, and private sector to strengthen the network of care surrounding mothers, babies, and families. Whether it's through access to community health care centers like Newark Community Health Centers or launching innovative grants that we are working on at MIA to really support the capacity of these centers. Together, these efforts reflect New Jersey's commitment to leading with urgency and compassion. So I really encourage today's conversations around policy, innovation, prevention, and whole person care to move us beyond simply identifying the barriers, but instead highlight some of the solutions, because the true measure of a healthy community is reflected in the strength, resilience, and well-being of the families who live within it and call it home. So at MIA, we look forward to working with you all and to continue building a future where all women, mothers in New Jersey have the opportunity to their care, to care first and really focus on their ability to strive and to flourish. And so again, congratulations and thank you so much, and we look forward to many, many, many great work and partnerships with you. Thank you. Thank you.
Yes, we're very excited. Yes, I told her don't go too far because we keep her working and she does an awesome job. So thank you to Mia for what they do for us here. And I heard about the grants. Yes, okay. I'm going to write it down. There's some grants coming up. Now, as you know, this is Newark Community Health Centers, and we believe in quality health care, and it involves all of us. So I think you've been sitting too long, and we want to make sure that you get that blood pumping. So what we're going to do right now, before you have tea, because you realize we're going to give you tea, and isn't that amazing? Yes, because we're going to give you tea, but you also must remember what you're going to do when you get the tea. You're going to clap yourself, thank yourself for all the good things that you do and how you're accessing healthcare to take care of yourself. Is that a promise? Right, and the person who's going to take us through this day is no more than Carissa Lawson, who is an anchor woman, been with us for many years in New Jersey and will continue to be in New Jersey, even though I see your face across the river. She's a New Jersey person, and you all know that. The most amazing thing about her is that she was called into action to be an advocate for women's health, and she has accepted it, and she has always engaged herself to allow us to have these events, and we also have the gala. She does a lot of things for us in this community. And so without further ado, I would like to introduce Carissa Lawson. Yay!
Thank you so much, Dr. Clark. Now, I know that we're running behind, so I don't want to take up too much of your time. I want to ask our first panelist to come up on stage. You all know who you are, and I'm going to have you introduce yourselves when you sit down. So each one, come on up. I'm going to call your names out so you can have our organizers help to gather them up. Ms. Cayasos Gill, please, Assemblywoman, come on up. Okay. No, that's... Go ahead, yes. All right, so we have Reverend Roundtree, you were just up. Come back up on the stage for us. Patrick Council, you were up on the stage prior. Come on back up. So we have one by one. All right, so I'm going to have each of you just briefly introduce yourself to the crowd.
Good morning.
Good morning.
All right. Good morning, everybody. Thank you so much for the invitation. I am super proud to be here and very thankful to be around this incredible room. My name is Assemblywoman Alexon Collasos Gill. I represent the 27th Legislative District. I live in Montclair, which includes Montclair, West Orange, Clifton, Roseland, Milburn, and I know exactly where I am. I'm in Newark. I'm a graduate of Rutgers University right here in Newark.
All right.
So I lived around the corner from this place right now. So I'm incredibly happy to always be back in Newark. So thank you.
My name is Reverend Louise Scott Roundtree, council member at large for the city of Newark. That's citywide, covering all 5 wards. I'm also associate pastor at the Good Neighbor Baptist Church in the city of Newark. I'm also the founder of the Newark Interfaith Alliance, which I founded under the leadership of Mayor Raz J. Baraka when I was the first woman appointed to be manager of clergy affairs in the history of the city of Newark. Now I oversee over 650 faith leaders in the city of Newark that I organize and meet with on a weekly basis. But I am a champion of better health because good health is really where your wealth is. Thank you.
Good morning to everyone. I am Councilman Pat Council. I'm the councilman of the South Ward.
Technical problems here. Go ahead and pass it.
Go ahead.
We got outside voices.
There we go.
You preachers,
That's right. So I'm the current councilman of the South Ward here in the city of Newark, the largest densely populated ward in the city. That's home to Beth Israel Medical Facility. Also the pastor of St. John Baptist Church in the city of Newark, 137 Fairmont Avenue. And it's not on. We'll figure it out as we move along. And so our work around health initiatives is critical, and that's why we're here to have some discussion to really talk about policy initiatives and what our role and responsibility is as legislators to ensure that our community is getting the best health care as possible.
All right, we may have to share a mic, but that's okay. Let's keep it moving here. All right. So I know that the theme today is, rested and radiant. And I know oftentimes as women, sometimes, instead of feeling that way, we can feel run down and roughed up, right? That's exactly right. Isn't that right? Sometimes we can feel that way. So our panelists are going to tell us how policies and systems can sort of be a catalyst to reshape women's health this morning. So our first question for you guys, what's one policy that your city is still defending that you realize is quietly making it harder for women to stay engaged in their care, and what would it take for each of you to actually change that? We'll start right here.
So barriers and things that we can be champion.
Yes,
right?
correct.
So one of the barriers that we have learned, and again, one of the many things that we have to talk about is obviously health insurance and making sure that we women have proper health insurance that is adequate, in coverage. And that requires, and it's not just employment-based health insurance, which is really important, but also whether it is Medicare, whatever kind of insurance that is actually not just the bare minimum, which is what we are seeing, but is actually cover the needs that we have. One of the many barriers that we have is not only when we have health insurance, but we're speaking about the expensive, the out-of-cost expenses, whether that is your premiums that you have to pay, or it is whatever the coverages that you have. There's still many barriers. I have notes because I talked about this one. but those are continue to be barriers. So, and that's we're speaking about a population that already has some sort of coverage, and that's still a barrier to that because again, that produces transportation needs, making sure that again, when we have that coverage, that actually people are, women particularly, are able to get to the places that they need to get to at appropriate times. And the third thing is, again, there's so many barriers. I'm just bringing the biggest one with this, includes health insurance. And I will say this, give me a second, it's because I am in a committee, I serve in a committee that is regulated professions. Regulated professions means a lot of things, but bills come into my committee to discuss, for example, additional coverage for health insurance. So again, insurance companies are coming to us to tell us that no, we can't allow certain things to be covered because it's going to make it more expensive. And we've realized that no, it is not true. Health insurance should be able to cover whatever a doctor, a physician tells that it needs to be done. And so we're seeing a lot of barriers on that end. So biggest thing I can repeat is coverage, proper coverage of health insurance for all women, for all families, not just the women, to your point, but families, the men, the entire community. Biggest one.
Oh, here we go. So one of our biggest barriers, I'm good.
She's good.
I'm good. One of our biggest barriers, I know, in this time is our immigration population. They're not able to seek or scared to go to seek health care because of our policies now that are in place. I thank God for the Newark NCHC because there are things that we do that are not like other municipalities. We'll see anybody. I don't care where you're from. I don't care who you are. Whatever your nationality is, whatever the color of your skin is, no matter how short you are, tall you are, straight your hair is, nappy it is, we're going to see you and your children in Newark. Because there's so many barriers across the country, which my colleague has just spoke of, and it's not just enough to say 1, 2, or 3. Anywhere you cannot get the proper health care, the proper treatment, the proper diagnosis, the proper examination is a barrier. And that covers a multiplicity of areas. So the back end of that question is we need more advocates in Washington, in our state, and on our local level to advocate for the type of policy we need in place, not just the Affordable Care Act. That's like a Band-Aid to me. I don't know whether y'all got that. It's a Band-Aid. It's like, well, we're going to give you a little bit to help you get through. There should be no one in the world, in the United States of America, not America, they can't go to the doctor and be told that I can't operate on you because charity care won't cover it or you don't have. No, there should be nowhere. Not when they call this the land of the free and the home of the brave. That's what they call it. So there are multiplicity of barriers. Councilman Council is going to talk about some of the things I'm sure that we've done for affordable for our employees, which can maybe help some of the other municipalities that are being priced out in insurance. Priced out. Our elders can't get proper care because they're on Medicare that won't cover this and Medicaid that won't cover that. So, yeah, we need larger advocates, more advocates to speak in government on a larger scale that can break through some of those barriers that stop all of us from being able to have access to the proper health care.
Hello, testing.
Yes, it's working.
There you go.
We got to get this sound thing right. Right, because that's a problem. Sound is important anywhere you go because it helps to deliver information. And so some of the main barriers that we continue to face, especially in black and brown communities all over this country, is information dissemination. It is paramount that we're able to get information out into homes of individuals that may not have access to, YouTube or have access to streaming services or information that they may need. Because the reality is there are some poverty-stricken communities here where individuals are living at a low rate. And we continue to fight over all of those kind of barriers. We continue to fight over barriers of just straight doula care. And that's why we've created, even in this community, some of our nonprofit organizations have hosted doula classes, have got registered doulas engaged and involved, and more importantly, streamlined and taking services to individuals. Our Newark Health Department does a wonderful job at taking breast screening services from the building out into the room, because into the streets in the community. Because it's important that our people identify that the health services and things that you need are just not housed in the building, but you have access to get them where they are and to meet them where they are. And we have to begin to change the language barrier, the customer service barrier, and things that are happening in our healthcare facilities. Because ultimately, when Black and brown women go to hospitals and healthcare folks, they're not there to fight. They're there for you to fight for them. And so because this kind of engagement is happening, it keeps many of us, especially men, from going to the doctor and doing what it is that they need to do in terms of regular exams, in terms of checking up on their physical health, to make sure that they are in alignment, whatever that doctor may look like, right? From a colonoscopy to just gynecological care, we have to be able to put ourselves in situations where most things that are happening in our community are not friendly, and we have to create a friendly environment so that when they enter these environments, they feel safe to be able to open up about some of the issues and concerns that they have, because generationally, most people were not taught to talk about things around their health, right? That centered around their health. What Big Mama told you in the house, it stayed in the house. And so if they had health conditions or health challenges or heart problems or hypertension issues, some of those things, even some of our younger generations may not know to go to explain. And so we have to increase information dissemination and decide how we determine that information and give back to our community and our families, so that when we enter these centers of care, we can be able to dictate, determine, and dialogue about what is happening and what best practical services we need, instead of trying to let people dictate what it is they want to do for us and to us.
Important stuff. Important stuff. Wonderful. Assemblywoman Collazos-Gil, with limited funding and staffing, how do you decide which programs to prioritize, and what are the trade-offs when you have to do that?
Well, thank you. Well, it is incredibly important that we need to choose one thing over the other. So prioritizing is incredibly difficult because, again, we believe that, again, we can talk about preventive care, which is incredibly important, education, the resources that we need, because we can have those resources here, but if the community doesn't know where they are, then they're useless. So one of the things that the councilman mentioned is making sure that those communities, that the information is there. So if we needed to prioritize, which again, it is a horrible thing to say that we need to prioritize because of money, because of funding, because healthcare, it is so incredibly crucial, not just for it's not just, it's a socioeconomic thing as well. So when we think about making sure that women and families are cared for, that their healthcare is cared for, that's also an economic indicator, that we also need to do this for that reason as well, if that's what matters. But again, preventative care is important. Making sure communities and community outreach is prioritized, because once again, resources are found in so many different places. But if the community is not reached, if they don't understand where the resources are, if we cannot reach to those communities in a way that they want to be heard, whether it is an actual language, whether it is, and the different languages, not only, not just the language itself, but the way that they hear that information, whether it's TikTok, whether it is, to our younger generation, whether it's Instagram, if that's where they're getting the information from, then that's how we need to reach those communities. And that's an investment that we need to put in. But also, in order for us to get to that place, then we also need to understand the communities that we need to reach to, which is important this is the reason why these kinds of organizations, these centers, and being run by the community that they serve is so crucially important. It cannot be outsiders, Because again, this is the community that you know best. You know how to communicate to that community, and that's how we need to be able to reach them. So as policymakers, let's say in Trenton, we need to make sure that we lean on to these kinds of organizations so we can come up with policy that actually addresses the issue that we all want to do. Because I think that we all legislators in New Jersey and the state, we all want to do the same thing, but we just need to make sure that we are doing it for the right, the intended reason is actually reached. That's my biggest thing. Thank you.
Reverend Roundtree, what policy?
Can I just say?
Okay,
I
sure.
Want,
Very briefly,
I want to
yes.
piggyback on that because what she's saying is true, but the real word is partnerships and collaboration. Because we need to partner with these organizations to get that information out, as he's saying, to the community. So we in Newark, the women and the men, myself and Congresswoman LaMonica started several years ago taking the mobile unit to the street for cervical screenings and breast cancer. So we're not waiting, and we have not yet signed up over 100 women for breast cancer screenings. Then they added cervical screenings. I don't even want to start talking about what Director Caitlin, CEO of I, she's doing the dentist on wheels. I mean, sometimes while you waiting for them to come to you, they waiting for you to come to them. So that goes with the information. I said it about the church. When people see nobody in the church, they say, well, while you waiting for them to come in the church, they waiting for you to come out in the street. And so since we have that accessibility and those opportunities to collaborate, when we see all the tables here, when we have job fairs, health fairs, we invite everybody. Because if you say job fair, everybody coming. At the same time, they might find an organization like SOLS, Office of Violence Prevention and Trauma Recovery. Because you do know health also is mental. It's not just physical, but that's another conversation for later on. However, I just wanted to say that partnership and collaboration. We partner with University of Medicine and Dentistry, which provides that mobile unit for us to do the cervical screenings, and I will make sure that I sponsor at least every 2 months somewhere in the city of Newark, and other municipalities do it as well, that mobile unit to go. And we sign the women up, and it is just amazing. Now the men, let me just say this, they decided they wanted to let folks know you got to get your prostrate, all that stuff there. So a couple of them, he and Councilman Crump are taking care of the men. But we're talking about women today, right? Yes. No, we're just talking about good health. How about that?
Mr. Counsel, I have a question for you. What policies have fallen short in translating into real improvements in access or convenience for women, and how should those policies actually improve? Because we're falling short in some areas. You have to admit that. Yeah.
That
It
mic
must
does
be the
not want me.
reception of where we're sitting, sir.
Yeah. So when we talk about policy initiative, even when Assembly Gill, made the statement about prioritizing, I think one of the things is we should never prioritize health. Health should always be at the forefront. It should be at the forefront of everything that we do, because the reality is that now even the working class individuals who are now paying higher premiums are falling into the same kind of systems as individuals that have no health care at all. And so we have to be mindful that there are individuals who are working are falling in the same calamity because of these high costs in health care that may not be able to pay their own insurance bill, because so many companies now are falling away from it and asking employees to pay on those higher premiums. And so those are some of the policy things where we fall at, to be able to hold some of these corporations and companies accountable for making sure that they're paying into their healthcare systems, that employees that are working in these places can have decent, affordable healthcare that is important in primarily helping to ensure that family coverage is decent and that individual coverage is decent as well. And so we have to stay on the backs of our federal partners as well as our state partners to ensure that they understand that when you get at the table and talk about people's health care, that should never be negotiated, because it is a right. It is a human right for all of us to have health care and to make sure that we can walk into any facility and get the services that we need at any time. And so we want to be particularly intentional about when we talk about policy initiatives to ensure that we're holding these corporations accountable for what it is that they're supposed to be doing in their investment in healthcare, to make sure that the working people that are working for them to build capital, to build wealth generation for them, at least have the basic decency to be able to go to a doctor and see a doctor in a very functional way.
Yeah, absolutely. Well, what is one concrete action or policy shift that is necessary and achievable in the next couple of years to improve women's access to care as we look ahead? Who would like to take that on first?
Listen, universal health care. I mean, it is achievable. I mean, it is an uncomfortable conversation. It is an absolutely uncomfortable conversation in many rooms, but the more we hear about the premiums, about healthcare prices, health insurance prices, hospital prices, the lack, I mean, it is even more expensive, but we are now learning, and we keep learning of how many people are falling behind in healthcare, and getting the treatment that they need, even with higher costs. It is costing the state, our municipalities, more money. It is costing taxpayers a lot more funding. It costs individual members who actually pay for their insurance more. So I know that it's a really uncomfortable conversation to have in many rooms, but universal healthcare is something that we should be working toward, because it is a healthcare crisis that we're having. And it's not just, it's a healthcare crisis because it's really expensive. It's not because we don't have the doctors that they don't want to treat it. It's not because we have a population that does not want to seek that treatment. It's simply impossibly, it's incredibly expensive. So I know that is, but again, I think that it's an achievable goal. I know that it's aspirational right now in terms of the timing, but I think we need to keep working toward that, because healthcare is a need. It's something that we should all be working toward. So I think that's it. Two, and again, and I will just add one more thing in terms of health insurance, and it's not that I don't like the health insurance. I mean, they're doing, it's great that we have it, but we need to do better. And we need to force health insurance companies to do better. One of the things that Dr. Clark mentioned is that even the amount of time the doctors spend with their patients, it's not enough, and we are seeing that that's an actual problem, that they should be able to spend more time with their patients, and it should not be dictated by health insurance companies. It should be dictated by the need, by the doctor. If this patient needs more than 20 minutes, because not only we talked about, the health, the mental drainage that we're having, if they need a little bit more time to just vent their needs, or even to explain what their illnesses are, they should be able to do that and not be penalized with funding or how much they get paid per patient. We just need to go back to compassionate, caring, and remember who the client is, and it's the patients.
One thing I've noticed is that as the costs go up, the coverage goes down.
Coverage goes
They don't cover
down.
this medication anymore. They're not covering. They're making it harder for you to get certain tests, and all of these doctors have to jump through hoops to get you covered. It's crazy.
I will. Let me just. We have one. I'm sorry. I just had spent some time with one of the assemblywomen who is she's a doctor. She's the only doctor right now in the Democratic caucus. She's an incredible, just human being. She's also a physician. And she tells me how much time she as a doctor spends with insurance companies trying to explain and to kind of almost negotiate for her patients. And this is time away from what she should be doing, which is literally just paying attention to her patient, to the needs, instead of paperwork that needs to be done. So anyway, thank you.
It's getting worse. Go ahead.
So you said something very important. I think it's the signal. You can only certain places you can get it. So we're going to stand here. You two,
We'll be over here.
You two in good spaces. When you start talking about a doctor not spending quality time, they call doctors a practice. I always say God is the real doctor, but doctors practice. That's what they call it, a practice. If I ever sat with a provider or a doctor that did not have time, I would have to find another doctor or have a conversation with the doctor, because There's a lot of people that go misdiagnosed, undiagnosed, because at some point, it's like teachers. Not all teachers have the compassion. They chose it as a career, and they got in there with those children and decided, maybe I want to do something else. So everybody's doing things on different levels. But you got to make sure that when you are with a doctor, there are providers that you don't have to spend a lot of time. Like, I needed to get a prescription for something. And when I called the doctor, I says, my insurance won't cover it. She made one phone call. Within 48 hours, it was covered. So, and it was only one phone call. So it's like, do the doctors take the time to have access to what they need to? Because that is part of their job. I mean, if you have to stay in your office till 8 o'clock at night to see your patient, you chose that career to be a healer. So there should be no compromise with healthcare professionals, with healthcare providers, with doctors, with nurses. But if you found out during COVID that there were individuals that chose a nursing professional, that if you fell out the bed because they were short of nurses, by 24 hours, they was ready to quit. So even they have limits. But that piece that you just stated, we have to really, and I'm going to tell a story before we leave here. It will only take 30 seconds. Because when you're pregnant, when you're at a heart condition, when you know these things in advance, and you sit with a doctor that wants to rush you through, anything could go wrong. Then we start talking about infant mortality.
Okay, all right. I thought you were going to
They
piggyback off that.
They were real good on it.
Okay.
But you definitely also have to touch on the mechanisms and systems that were put in place, to deny us the kind of proper health care that is needed. And so when you begin to look at all of these things that are happening around it, one of the things in the city of Newark, we struggle with this all the time because they don't look at the health of the individual, right? They look at the health of the organization. And so when they look at your organization, they deem and grade your organization. So if they believe that your organization is sick, then automatically you become sick and you have to pay for the sickness of the organization. And all of those things are systematically attached to getting more money from people. And we really have to begin to deal with that in a legislative way and on a federal and state level. And our legislators on those levels cannot be afraid to fight those battles because it deals with the health costs and care of individuals. I just imagine if you're making $40,000 a year and you have a family and you have to pay almost $300 or $150 a month or $200 a month just in family care. And so your paycheck and your health care is not going to help you reach the standards and what you have to do to either be able to make bill payments, rent payment, if you
Pay
had a
gas,
car payment.
we know what's going on
right.
with that
So
these
then
days.
here's all of the other ancillary issues that we talk about, right? When we talk about transportational issues, then we talked about child care issues, and you're trying to lay it all on the line, right, to make sure that the little money that you have here and the money that they take out of your check can be able to stabilize you and your family for that period when we really need to begin to make dents at this system that has put us in a situation where it puts us down, but it lifts up, corporate greed.
Hard to stay rested and radiant when you're going through all that. That's a fact. All right, so what would have to change tomorrow for women to stop adapting to the system and finally have the system to adapt to them? We see that in other countries. We do see that, right? You're smiling.
Wraparound services. I mean, make it easier for, again, organizations like this one where you can have every single thing in one place is incredibly important. Meaning that you have, as we mentioned, that we have mental health services in the same place where you can just make an appointment for a mammogram. That you have a physician, that you have someone those wraparound services is incredibly, it's crucial in making it easier. I'll give you a quick little example right now. I got my mammogram today, yeah. But let me. But I will tell you something really interesting in terms of her family. Is I had my appointment at 7:30 in the morning this morning, and my kid, my son, my 17-year-old, last night we were making the schedule for today, like who's doing what, who's doing the drop off, the pickup, all of this. So I said, no, listen, we got to figure out. I have to leave by 7 in the morning. And he's like, no, what do you have to do? And I had to explain to him, like, no, I have to make an appointment because for the last two appointments, it's been in different days, time of days, and I've had to cancel because something jumped in, like a meeting came up, you guys got sick, I had to run and pick you guys up. So I needed to do it at 7:30 in the morning so I can actually make arrangements, and I have no chance of like missing the appointment. But these are the kind of barriers that we're speaking, and so on. And then the second one, after I have to do a follow-up. But one of the barriers right now that I saw is that I couldn't make an appointment right there for 6 months. I have to wait until my doctor makes the prescription, sends it out, called in, which is the reason why it took me last time about 2 months to 3 months to make an appointment, instead of very simply, I am here. You told me that I need a doctor's appointment. You told me that I need to schedule this 6 months from now. You told me this. I'm going to call you later on to ask for the same thing. And later on, you'll be busy. I'm going to be busy. My insurance, my doctor, it's going to take another 3 weeks by the time I get around. It is an inconvenience. And I'm frustrated, and I have the luxury of being frustrated without any medical illness, like I'm fine, I'm healthy, I can make the appointment, I can do all of this, but can you imagine if you're not? Can you imagine if the diagnosis was unfavorable?
Or if you're taking care of a parent yourself on top of, sick children and all that. Yes.
So all of these are the barriers that we have, but if we have something as simple like, yeah, sure, let me take care of this, let me make the appointment. So wraparound services, making as easy for women or for patients as possible. The more technology we have, we talked about AI, the more complicated it becomes, and it's just even more frustrating. So,
excellent points.
I don't know if I answered the question.
Yeah, medical. Yeah.
The question is, how can we change it?
To change it, and one, we have to begin to go back and look at these systems. Medical care has become this kind of herding system, right? Of moving people in and trying to move people out, and it's lost its intimacy. And the reason it's lost its intimacy is because as long as Big Pharma continues to grow and demand more and want more, right, they put more pressure on these institutions and these doctors. And so the doctor that would see you every other day, or you can call and pick up the phone and talk to, now can't talk to you for 6 months down the line or 5 months down the line. And far be it if something happens where they tell you to go to your regular physician, now your first approach is to get to the emergency room. And so our emergency rooms are overflowing with things that could be able to happen at our primary physicians. Our primary physicians are overflowing because of the mandates that they're getting to produce, create, and continue to push whatever it is, even from Big Pharma, from medical prescriptions or drugs or examples of drugs that they have to push out to different people to meet their mandates. And all of that, you miss the humanity of the person that's standing right in front of you, right? And so you miss me. And when you miss me, now I'm afraid to tell you that my chest is hurting. Now I'm afraid to tell you that my leg is bothering me, because now I'm expecting that you want to experiment on me instead of healing me and helping me.
Wonderful.
Yes. And so our trend of thought, our mindset, we have to, because I don't know how many, we're all patients in the room. I don't know how many doctors are in the room, but I do know we have some healthcare professionals, providers, and organizations. This room is the room that has to really spread the information that health is wealth. We put our wealth mindset on money, jobs, position, power, but the priority is your health. Because if you don't take care of your health, none of that really matters. So your health has to be at the top of the list. Big Pharma are the biggest drug dealers in the United States of America, and then some of y'all must not be clapping because y'all go to them, but I don't know. But the truth is, they are. The pill you on, the stuff you taking, they wanted me to take, what was that? Something for cholesterol, one of them pills. Now, I don't know what it is because I didn't take it. But they told me my cholesterol was high about, I'm not telling y'all to do this. And I went and I looked at preventive.
Right.
Because I asked for what the side effects were. They said, oh, Roundtree, everything got side effects. I said, no.
Right.
I want to know what. And they started talking about your legs cramping, whatever this thing was for cholesterol, because I guess it's getting you. I said, I need my legs to walk. I don't need no cramps, because I walk all day. That's right, in heels. Y'all know me. And I got on low ones today, but anyway, I saw that oatmeal every day, real oatmeal, and fish oil. When they told me I had to take a pill, this was about 10 years ago, baby, I was every day, oatmeal in the morning. Yes. And within 90 days, my cholesterol was down to normal. Now, I'm not telling you, y'all can clap. Now, don't y'all go doing that if they got y'all on some cholesterol, because I don't want nobody having no stroke or nothing, because Roundtree said eat oatmeal. But I did that. I will not see a doctor. I had the first African-American surgeon at Beth Israel as my primary, until they told me he was in the parking lot, couldn't find his keys or his car because he had a stroke. I had to change my doctor because I couldn't then depend on someone who had just had a stroke. I didn't want to put Dr. Cruz, Beth Israel, first black American, you know. And so we also have to be mindful that I don't care what your job is, other than your family, go get it checked out. I don't care what the barrier is. There's a way to get the health care you need if you are persistent. Don't have a stroke or a heart attack or something to do with your weight, because you'll be no good for your family, your children, or your assignment.
There you go. There you go.
You've got to take care of your health.
Absolutely.
There
Absolutely.
are no barriers when it comes to your body. I'm on a diet right now, by the way. I changed my eating habits. Because during the election, I was eating fried chicken and potato salad every night, 11 o'clock. I know I was on the way to 300 pounds. And I want to look like Carissa Lawson, Channel 2, CBS. But anyway, I probably won't look like that, but I bet you I won't be this big when you see me in 2 months. But listen, so, because these things matter. Yes. I got an 11-year-old granddaughter. I want to see her graduate from high school. Right. Hell, I want to see her next month. There you go. Because it can happen just like that.
Absolutely.
Just like that.
Wonderful.
So all this stuff we talking about, health care, policies, we are the first voice and advocates for whatever area you want to choose. I know Crystal with Urban League has her platform, and I'm going to give this woman a shout out, and then I'm going to shut up. Director Caitlin, she's our director, and I love Newark. I love Dr. Clark, but this woman right here, there's not a service in the city of Newark that she hasn't found a grant for. And I don't know where y'all watching, if it's on live. We don't have to look for money for not one health care service at her Mary Liza Mahoney.
She'll be up next. She can talk about it.
But I'm saying, yes. Like, that's important. Yeah. She's not going to talk about the grants because that's what we vote on as legislators. Everything she puts before us on the Newark Municipal Council is money she found for the city of Newark to provide health care on all levels.
Wonderful.
All levels. All levels. Heart, head, body, mental, toes, whatever it is. So talk to her.
Yeah, well, they are going to hear from her, so we know that.
No, I'm telling them when they leave here, they better get a number.
Well, on that note, I have to say I was at the gym I go 5 days a week, by the way, 4 days a week. I do go to the gym a lot. And they had something up. They said you have 1,000 problems until you have a health problem, and then you only have one. And I posted that out, and everybody was just amen to that. That's exactly what we're about today. So important. We could have you, all three of you, up here for another hour, but we have other panelists that are coming up. Thank you all. A round of applause for our first
Thank you,
round
Carissa.
of
Thank you
today. Thank you so much.
Thank you, Dr. Clark.
Oh, picture. Oh, a group picture.
We're just glad to have you. Come on, this was so awesome.
Wait, not me.
Oh, let me put this down then.
Thank you so much, guys. Thank you. History. It's all for history. Have to. Oh, thank you so much. Okay, I'm going to ask our next scheduled panelists to come up to the stage. Dr. Clark? Oh, okay. We're going to move the chairs. But as we get the chairs moved around, Ms. Alsbrook, Mapanya, and Ms. Pierre, you're coming up as well. Yes, okay. Actually, let me move over here. Miss Orr's up? Okay, great. It's a big panel, so we're gonna keep it brief. We know you guys, but listen, it's good stuff we're bringing to the audience today. A lot of good stuff we're bringing to the audience today. So I'm gonna have each of you give a very brief introduction, and we're gonna start with you. Go ahead.
Well, good afternoon, everyone. My name is Kimberly Pierre. I serve as the Deputy Director of Health and Senior Services for the Township of Irvington, and it's a pleasure to see you all today.
Ms. Orr.
Hi, I'm Crystal Orr. I'm the President and CEO for the Urban League of Union County, and it's great to be here as well.
Is this afternoon yet? Good afternoon, everyone. My name is Catlin Alsbrook. I am the Health Director for this great city of Newark, and somehow managed to have a second job as well as CEO for our federally qualified health center, Mary Eliza Mahoney Health Center, which, by the way, is named after the first Black woman to serve professionally as a nurse here in our country.
Good afternoon, everyone. My name is Valencia Maponia, and I have the distinct pleasure as serving as the Director of Health and Human Services for the city of East Orange. I've been a public health practitioner forever, so it's exciting to be here, and thank you, Newark Community Health Centers, for inviting me.
Hi all, happy Thursday. I'm Dr. Jenny Schrum. I'm the Director of Research and Evaluation at the New Jersey Office of the Food Security Advocate.
Wonderful. Thank you all for being with us this afternoon. Well, in your cities, what are the most consistent barriers preventing women from staying engaged in care, and which of those are within your control to actually change? Because you have a lot of power. We have a lot of power sitting on this stage.
So one of the things we all are noticing is the consistent rising costs of everything, right? The cost of food, childcare, transportation, housing. And the one thing that we can work on is making resources more accessible for our residents, right? Finding ways to collaborate, as we hear, right? There's power in numbers, and finding ways to maximize what's already available and making it known as well.
Yeah, so I serve on the side of a nonprofit, and so people come to us because of the rising costs. In rental, they need rental assistance, mortgage assistance, they need jobs, they need opportunities, and we also serve a reentry population as well. And what we do on our side is at least provide the guidance and lead them to the resources. So as Councilwoman Roundtree mentioned, that we are the ones to share the information, and that's what we do at Urban League. And then if we have the funding, we actually give them those assistance so that they can stay in their homes, because one of the biggest stressors that then leads to the detriment of their health is not having stability. So if you don't have a home to go to, if your utilities are going to be turned off, now you're stressed out. So you're not worried about going to the doctor because you need a place to live. And so that's where we come in, and we also do have mental health counseling that we provide for free as well. So we're like, hey, we know you're stressed. We're going to help you on this end with housing. We'll help you find a job. But also, please come talk to someone for free because we need you to be whole for your family.
I would add a couple of examples, and we've done this at our health department in our health center. One of the barriers that we recognize is time, right? Because we're all trying to achieve this balance of work and our personal life. I know me personally, and I'm a health director, so I should know better. When I call to make a doctor's appointment, the first thing I do is open up my work calendar. Okay, so how am I gonna work this appointment around my job, right? Or work that I have to do related to my child. And so, you know, one of the things we look at is having non-traditional hours of operations, right? So I believe it was the Assemblywoman that was part of the first panel. She talked about having a 7:30 appointment for her mammogram. So looking at opportunities to either start as early as possible so people can come in before they go to work, or staying open later so that they can come in after work, or having weekend hours so that we're not competing with their work schedule, but having non-traditional hours of operation to support working families. Another example, and this speaks to the importance of partnership. We, through a partnership with RWJ Barnabas Health, are now able to provide Uber health services to our patients. And so for those who are experiencing barriers related to travel, and the cost of gas is ridiculous these days, and having to transport a number of children to a medical appointment can be a barrier in and of itself. And so by being able to offer Uber health services, whether you have a car or not, whether you have to take 2 or 3 buses to get to our health center, that is no longer a source of barrier, right? You can call, make an appointment, the Uber health driver comes to pick you up from your home and then takes you back home after your appointment. We can also use that service to take you to the pharmacist if you need to pick up your medications, or take you to your behavioral health appointment. And so it's not just focused on the services that we provide within our brick and mortar locations, but also those that extend outwards, because it's not just primary care, it's also the extension of care that we need to address.
So we talk about access a lot in terms of extended hours, et cetera, and you spoke about it, Dr. Clark, and sometimes not accessing what's there. But I want to look at access from a slightly different perspective, where a lot of times our access is a phone call to make the appointment, as it is. How are we going to use technology to allow our women to have access? So in the middle of the night, when you have put the baby down and the husband is gone and everybody, and you've washed the dishes, how can I then make an appointment to see the doctor? Can I go online? Can I use that little phone in my hand to do it? We're still very much challenged in terms of making a call to make an appointment for the doctor. How are we going to start using these QR codes, etc.? And case in point, I'll use it as an example. So prior to going to the city of East Orange, I was at the University Hospital with the mobile mammography team. Hey, where are they here? They're here, so I want to shout them out as it is. And one of the things we did was to institute a QR code system. So you could set your appointment in the middle of the night. So that's something that we may want to look at in terms, because barriers exist in many ways, from the structural in terms of can I come in, can I what, but there are the other barriers. How can I then find the time within the non-traditional times to do what I need to do?
It's hard to go last. I agree with all these things. So what I've seen in the food space, when we want people to be able to access healthy, nutritious food, right, for their health, one barrier can be not feeling heard on what kind of food you need and what you eat, right? So we all have different diets. Some people may be diabetic. Some people may need low salt diets. So for specifically for populations and people who are going to food pantries, right, what we really advocate for is creating opportunity for someone to advocate for themselves and what they know is best for themselves already, right? So if we can set up a pantry so that you can shop and choose on your own accord what foods are best for you, that can be a lot more supportive than being limited to just a bag that maybe is closed and you don't even know what's in there, right? So I think self-determination and agency and uplifting that is really empowering. We want people to feel empowered in deciding what's best for themselves and their health and their family.
Well, Dr. Schramm, what does it take from a systems perspective, right, for women to experience not just food security, but nutritional stability, right, for the long term. And tell us what it means to have food security in the first place for those of us who don't know.
Yeah. So, and I love to talk about food security, so reach out anytime. But food security is not about just having food in your hand, right? It's about having food that is healthy, that's stable over time. So a piece of that right now, we're seeing a lot of happening globally with food systems, right? There's a lot of chaos. We need to support local farmers so that we have healthy food grown in our backyard and it's easy to go get it, right? Absolutely. We need to make accessing things like SNAP and WIC easy. It's really hard to sign up for programs. It's hard to get school meals. Make it easier, right? It's like we talked about time. Navigating systems to get food it's like a full-time job to get to the pantry, get the different SNAP and the WIC. So I think making the system work for the people is really important. And what's really hard to do, but pays off times a million, is listening to communities, spending the time to do focus groups and interviews, spending the time to survey people and design your programs around what they're saying they need, right? It's not about being prescriptive out. It's about listening in and then actually implementing that and evaluating it and seeing if it's working. We tweak over time. The world changes. People are complicated. We're going to have to always be adapting. So we have to build in that flexibility and understanding at the systems level.
Very good. All right. Well, based on your role, Ms. Alsbrook and Ms. Orr, I'm going to direct this to both of you. What's sort of one concrete action or policy shift that you believe is both achievable and necessary in the next couple of years to improve women's access to care? Ms. Orr, you can start.
So I would say one thing that definitely we have to consider in terms of policy shift now is what is covered under insurance. So I can even talk from a personal perspective. So they have now changed the name of PCOS. I have PCOS, polycystic ovary syndrome. Literally, like this week, they have changed it now to polyendocrine metabolic syndrome. I think that's the new name. So with that, it impacts so many women from a hormonal perspective and an endocrine perspective, right? So, I mean, everything from infertility to lack of sleep, diabetes, your weight, your skin. But I'm someone who has experienced acne since I was 11 years old. Once you turn 18, they do not cover acne anymore because it's considered cosmetic, but it is truly a hormonal issue, right? So we have to look at, in terms of the policy, make sure that the things that impact women are being covered. Also, the age that you can start receiving mammograms and different things. I have a friend who's only 36 years old who had just went through breast cancer. And most of the time, you can't even get mammograms for free until you're 40 unless there's a history in your family.
And more people are being diagnosed, women younger.
Correct.
And younger. Yes.
So those are what that is something dear to my heart in terms of policy changes, the ages that we can start getting a lot of these free exams, what's being covered under insurance, and not that it's all cosmetic or you need to include certain fertility aspects. IVF, there's more women that are having babies older in life now, and to even freeze your eggs costs thousands of dollars. So that is a luxury to freeze your eggs if you have the money to do so. But everyday people do not have that money nor the time and the resources to freeze their eggs, even if they want to have kids. So that's something that I definitely am going to advocate for.
And that's great coming from like a patient's perspective, right?
Correct.
That's great. Okay. Ms. Alsbrook?
Yeah, so my response to that question, and perhaps this is not achievable in 2 years, but I think we can start the process because we've done this already, is being more deliberate and intentional about removing bias from the healthcare system. And it doesn't matter whether it's implicit or explicit, right? It's the bias that dictates the type of care, the quality of care that we receive as human beings. And I'll give you an example. I don't know if any of you in the room follow, his name is Dr. Joel, and I follow him, I watch his videos. And in one of his videos, he talked about GFR, which is the glomerular filtrate rate that is used to measure the health of the kidney, right? And so the higher your GFR, the more functioning your kidney is, the lower, the less functioning it is. Now, surprisingly to me, there was a race adjustment being used for Black people, which increased the rate of their GFR. which means, if you think about it, those with lower GFRs are prioritized for specialty care. They're prioritized for kidney transplants. So by overestimating the health of the kidney in the Black community, we became less accessible to kidney transplants and other services that are critical to our overall health and well-being. And so in I think it was 2021, the American Kidney Foundation and the American Society of Nephrology came together and developed a task force to look into this issue. And as a result of this task force and this deliberate and intentional desire to address this bias that was existing in our healthcare system, they developed policy and influenced the implementation of policy that removed this race adjustment from how we provide or how we assess the health of the kidneys in people. Right? And so laboratories were then strongly encouraged to use race-neutral laboratory methods for testing kidney health. And transplant organizations were encouraged and have implemented their own policies to ensure race-neutral equations are used when determining whether you can have access to a kidney transplant. So I say all that to say when we are intentional and deliberate, we are able to impact change. And so I think hopefully I want to see more and more of this example of really affecting the healthcare system in a positive way. And I think one of the great things about it is as more of us become more representative in the healthcare environment, Black and brown and immigrant people who are not necessarily just, you know, the Caucasian group that has, you know, strongly led the development of medicine in our country for many, many years. As we become more representative, as the medical field becomes more diverse, it gives us more and more opportunities to remove this kind of implicit and explicit bias from our healthcare system that disproportionately affects Black and brown people.
Well said, well said. Well, Ms. Pierre, what strategies have been most effective in building trust with women who may be disconnected from or hesitant to actually engage with the healthcare system?
Start listening to them, right? Actively listening. A lot of times people come with, let me tell you what you're going through, or this is what it should be, but everyone's lived experience is different. We may all be in the same space, but how we came up was different. Our cultures might be different, and understanding how to adapt and be intentional when we do our programmings and doing services that are there for them or intended for them as well.
Ms. Mapanya, if you were tasked with redesigning one aspect of the healthcare system to better support the ability of women to stay engaged in care, what exactly would you prioritize?
It's so complex in terms of reimagining healthcare. But one of the things we certainly, you know, in a combination of literacy and listening to them, is to ensure that at the end of the day, we have where we meet them where they are, right? And it ties back into not just telling a woman what you want to give them, but what it is that they need. So it's important that we look at what it is that they want from us and meeting them where they are in terms of that. There's so many things in terms of policies. One of the things I think we need to look at really, and our Assemblywoman touched on it, is that access through universal care. And universal care, this is America. And if all the other first world countries can get it done, we can get it done too.
Yes.
Right? So that's
But there's an arrogance in America, right? We know better than everybody, and we don't understand that other countries, you know, get it right sometimes,
right,
you know?
as it is.
Yeah.
So we certainly have a responsibility to look at universal health care, and not necessarily only from a federal, but even in-house locally within our jurisdiction. How can we do a quasi-universal health care to address the needs of the woman? And there are many ways to do that. You can have, you know, whether it be grant funding, etc., to create that atmosphere that we have, that a woman always has access to care, is important, and ensuring that also our health facilities are meeting. You know, we talk about ADA and all the other things, but what about the health facilities that meets the mom's need, so that there's even a stroller park that she can park her stroller with the baby to come for service. So as I say, it's a complex situation, but I want to focus a lot on what is our universal care looking like for a woman as a policy, and how can we therefore have that available so that a woman has no fear in thinking that she's going to get a big bill at the end of the day,
Right.
or something is going to happen. And then the innovation behind that too, because we also need to move away from the traditional structure of healthcare and look how we're going to bring innovation to it. Mobile health is one way of innovation, all right? What are we going to do differently? And we have to start asking that question. What are we going to do differently? Healthcare has been structured over time as emergency, or this is how we've always done it. And it is time for us to be bold and innovative, and how are we going to move away from how we have done it to what is it going to need, what do we need for today? And I know I've said a lot in that, but really it's, at the end of the day, is the woman at the center, and ensuring that our systems are developed around her needs.
Excellent, excellent. Dr. Shrum, the theme, of course, of this year's symposium is rested and radiant, right? It's hard to be rested or radiant when you're worried about the prices of everything going up, from fuel to food prices, right? What does having the capacity to care for yourself actually look like for women navigating food insecurity day to day? And how does your office actually help to put that into practice and not just theory?
That's a great question. I hope we all feel rested, sooner
Especially after
rather
today
than
and
later.
our tea, I know we will.
So one thing I talk a lot about, it's kind of what you just touched on. The food system, especially for those that are experiencing food insecurity, an example would be someone who's going to a food pantry, right? Originally, that was created kind of in the 80s. It really hit its hot spot. And it was created for people when they are in an emergency. So you had something to rely on. If you lost your job, you knew you'd get another job eventually, right? But you could go to the pantry. People are now using some of these emergency services chronically. So I will go to a pantry and someone's been going to it for 5 years, right? That was not the original intention. So a lot of what we advocate now is, even when it's things like food security, everything doesn't have to be us focusing on just the emergency. Let's think about prevention really intentionally to get that demand down on this end, right? So how do we get people to be healthy from the beginning and support them at the beginning, not just come in when it's really complicated? And what I see a lot when you're in that emergency, when you're in emergencies kind of mode of needing food, that's incredibly stressful, right? Yeah. So let's avoid that chronic stress by having things like SNAP, a living wage, so that you're not having to get to that point, right? And that's what I would love to see, is the food system and food security efforts really being preventative. And some of that is supporting, like I said before, farmers and the food system that we all live in, right? The stores, the retailers, making sure they have what they need so the affordable, healthy food can be right where we live, work, go to school, play, right? That's all very, very important.
Yeah, and the problem is, it also is that there are people who don't fall under the threshold to get SNAP, right? And there's so many people like that they don't, if you don't make that cutoff, you're not getting it. And then there's a point where people were in a situation where they find themselves in a different situation that they had never imagined that they would be in. Absolutely. And then there's an embarrassment, like, how am I here right now? And then they have to go, and what do you do? And they don't know who to go to or who to ask.
And I think this applies to health too. The way we talk about food insecurity, we should not be othering people, right? Food insecurity could happen to anyone every day.
Anytime.
A hurricane happens, it knocks out our road, we can't get food to the grocery store.
Layoff of your job.
It can happen to anybody. So we have to talk about these issues, obviously elevating where there are disparities, but getting rid of bias by talking about that this affects every single person, so everyone should be valuing it, right?
Yeah, absolutely.
Can I just
go
add
ahead,
one quick thing about that, because I think this is important too. We've really, and many of the FQHCs are doing this, is really acknowledging the fact that food is medicine, right? And so, I think it was the Greek physician, he was a philosopher, figure in medicine, Hippocrates, who said, "Let food be thy medicine and medicine be thy food," because he recognized the connection between diet and our physiological processes, and recognizes that food, beyond just providing sustenance, right, has positive impacts on our health and well-being and can be used to prevent and treat chronic illnesses. And so one of the things many of our health centers are looking at doing is integrating access to nutritional food in the way we deliver care and provide medical services to our population. So food pharmacies, right, is an example of this. Creating a food pharmacy within your health center so that when the physician is providing treatment to you as a result of a diet-related illness, for example, part of this prescription of medication or treatment that you receive is not just a pill, but also a food bag with vegetables and fruit that you can
Oatmeal.
take home. And oatmeal. And
Where is she?
oatmeal that you can take home to make healthy meals for yourself, but also for your family.
Right.
And it eliminates the stigma, right, that you're talking about in having to go to a food pantry as an example, or the barriers or the financial, I should say, financial limitations, because not everybody's gonna qualify for SNAP or for WIC.
But eliminating the stigma, right? We have to start doing that. In the interest of time, this is going to be the last question, and we're going to hopefully the organizers will tell me that we have about 5 minutes. We're going to open it up to questions from the audience. So if you guys have been thinking, wait, I would want to know something else, I'm going to give you an opportunity to do that. And you don't all have to answer this question, obviously. But what should everyone in this room, city leaders, employers, community members, be thinking differently about after these conversations that we've had on this stage? How can we leave this symposium with power and with purpose? Ms. Orr, you'd like to start?
Sure. So I will start as a nonprofit leader, and what was mentioned earlier was collaboration, right? So as I'm sitting here and I'm just thinking, how do you get to the people? So, for instance, we have people who come to our office every single day. Urban League of Essex County has people that go to their office every day. They have a food pantry. So one is collaboration. The health centers or the hospitals can come to our offices and set up shop, even if it's once a month, because we have the people that are coming in. Same with the food pantries and the food banks, that if the the providers are there, while the people are there, while they're waiting in these long lines, maybe we can talk to them, we can give them information, maybe we can check and do a quick check for you while you're waiting in line, and then you can go back into your spot, right? So I think that is a way we can think about the collaboration of meeting people where they are. They mentioned the mobile vans, they mentioned going into the pop-ups, but also go to the sites, the organizations, the places, the churches, where they are as well, because that's where people go for healing and refuge, and they're in those places like our office because they want to put in an application to get their rent paid. So for them, that's more priority than their health, unfortunately. So while they're waiting in our office, now they can also get their health checked as well. So we can really collaborate in ways like that to meet the people where they are.
I know we're talking about women, rest, and radiance, but one of the things I would love to jump us to think about as healthcare providers, directors, etc., is how do we help our community to build its workforce to meet the needs of women? We don't have a lot of people. And that's because, one, we're not training at the levels that we should train. So we have these deserts. We're short on, primary care doctors. We're short on certain nurses. And I must give a shout out to Governor Cheryl, who just allowed the prescribers right for our NPs, because that was a challenge. And that in itself has expanded our ability to serve more and see more as it is. So I'm using the opportunity to plug that we have work to be done on the workforce development side of making sure that we can have the services that the women need to access over time, right? And I know we're in the age of TikTokers and influencers and all of that stuff, but we have to have that conversation with our young women too, how to look forward to being the next doctor, to being the next respiratory therapist, to being the next what? To aim high of what it is that they want for themselves and not for what the world. I call it the narrative, that lie narrative that you can settle, but how as women we need to strive for more. And healthcare has place for us as it is. And at the same time as we're doing that, we're building a robust workforce that can continue to serve our needs.
Talk about thinking differently and renewal of the mind. Absolutely.
And
Ms.
just
Pierre.
to add on to those who we're leaders, or we're also the people who are doing the services. We're the experts, right? Asking ourselves, are we really making things accessible? If we're the experts, are we ensuring that things are in the right languages? We have a high migrant populations in the places that we serve, right? It's not just English and Spanish. What about Haitian Creole? What about Portuguese, right? And for those receiving the services, continue to hold those who are working for you accountable. It's okay to ask. It's okay to follow up. This is what we're here for. And just remember, your voice matters. And you should never feel silenced, no matter how stressing or how tough it may feel in those situations, because we are here for you.
On that note, any questions from the audience? We have one. Okay. Just please briefly give your name and the brief question, please. We do smell the food, so I know everybody's hungry.
Okay, I won't take too long. My name is Sakina, and my question is, how can we advocate for more effective policies to support affordable housing and stable food prices that benefit women and their families?
Housing, something we didn't address. Who would like to take that on? Just one of you, please.
Well, I just got back from the Pomona convening, and City of East Orange was chosen as one of 16 cities to go through a process, and we're looking at housing instability and how that affects the perinatal to 3 age group. And housing instability is a real deal here, and it affects a lot of our women. So your question is advocacy. One is we have to show up and start having that conversation. Sometimes it's stigmatized that being housing unstable is because you're lazy, you don't work, you have a drug problem, and that's not true. There's so many different things that that could allow somebody to go or provide the opportunity. It's not even an opportunity that causes somebody to go into a housing unstable situation. So we have to be able to have that conversation. We have to have it with, because a lot of people think that homelessness, for example, is the vagrant that we see at the corner, and it's not true. So how are we going to have that as city officials with our mayors, our council people, that the definition of housing instability is not the people you see on the side of the streets only, but it's a lot of working people who are couch surfing, or they're renting a closet to live in because they can't afford rents in a typical situation. Rent now in New Jersey, in the average area here, is what, $2,000-$3,000 for a one-bedroom per month.
That's right.
So a parent or a mother, child, husband with just trying to get 2 bedrooms, that's more than your salary as it is. So 1, the conversation has to start, and 2, we have to integrate it. So homelessness falls under Health and Human Services for my city. So we do actually have a homeless unit, and we tap into grant funding so we can help to pay for like rental assistance or down payment on your apartments, etc. So that is something that has to come to the table as Lawton Part as one of the areas of attention that we need to fund, and we need to ensure that we're listening to our community and seeing what is going on as it is. And there's much more that could be said, but yes, certainly.
Wonderful. Okay.
Just want to add, with the advocacy of affordable housing, you also have to one, go to your Congress and federal, because the definition of homelessness needs to change, and I've mentioned that to our Congress as well. And 2, advocate for at least 3 bedrooms in these affordable units, because a 2-bedroom is not going to help a family of 6 or 7. So, or if you have a boy and a girl, you need at least 3 bedrooms, and most of these units now that they're building they're not big enough.
Wow. All right. Any other questions from the audience right now? Okay, one more.
Hello, my name is Christina. I'm from NCHC. What strategies can women implement to safeguard their families against the rising housing and food costs?
Who would like to take that on? Ms. Pierre, you didn't respond before to anything. Would you like to take it? Since I put you on the spot.
Well, one thing I'll say is just being intentional and finding out what's available to you. We heard earlier about rental assistance. In most of our municipalities, we do have this service available, and sometimes individuals will count themselves out, right? I can't because of this. Don't count yourself out when you don't even know the qualifications or the eligibility for us to move forward to afford housing, right? That's a need. That's a health concern. If I had to think of anything else, not being afraid to ask questions, right? I think the assumption is that we should know everything. But if we were to know everything, we wouldn't have people in different professions, in different places, and in different spaces to come get information. Putting yourself in places to hear the information and passing it along. Sometimes the information may not be beneficial to you, but it could be to someone, your neighbor, or following, or someone that they may know as well.
I understand we have one more question. One more question.
Okay, thank you so much for this outstanding panel, and I learned a lot from your discussion. I represent Catholic Charities of the Archdiocese of Newark, and we work with the refugees. And this is an umbrella term where we have the people with TPS, with parole, with asylum, refugee status. I'm thinking, and I'm speaking about what we're facing every day. Most of them, they either are not eligible for Medicaid, health insurance, or they have a pending status. They applied, but they didn't receive the card yet. So we do know that we have the federally qualified health centers with whom we work, we collaborate to make healthcare accessible for them. But yes, they have the consultation on a sliding scale basis. Yes, it's very helpful. After that, if you go to the doctor, right, the doctor see you, they prescribe you certainly to investigate the problem that you present with. They prescribe a lab test. They prescribe medicine. And then you're blocked here because you don't have a health insurance. I was wondering, how can we think about a policy that would take this into consideration to make really healthcare accessible to those people who are here? They are human beings. Health wasn't supposed to be discriminated as it is. And for our immigrant population, we know that a lot of them, they are dying silently. And recently, a young woman, 25 years old, was diagnosed with cancer too late, and she died to cancer. This is just one example of how people are foregoing health care that they need to live, right? I don't even talk about prevention.
Right.
I'm
going to have to stop you there because you did ask your question. How do we reconcile this with the fact that there's just so much money to go around, period? Everybody does need health care, but it is a system where money is necessary. Who would like to take that on?
I'll try and take that on. Federally qualified health centers are designed to meet people where they are, whether it's your financial status, your insurance status, your residency status, or any other status. That's what we are trained to do. And so when you come into our health center, if you have insurance, great, give me your card. If you don't, let's figure it out. What is your income? What is your household size? What is your residency
And they
status?
pay what they can afford.
And they pay what they can afford,
Okay.
which is great.
Well, maybe they don't know that that they have this opportunity. They don't know
Which goes
about
back
it.
to what Councilman Council said about making sure we get the information out. Because one of the other things that we do as federally qualified health centers is we use our program income to be innovative and creative and try and address these issues. So for example, at our health center, we have a prescription assistance program. So if you're seeing the doctor and you're uninsured and that doctor prescribes you a medication, we can connect you to our medication assistance program. We have a nominal $7 copay, and we cover the cost of the drug. We cover the difference in the cost of the drug, no matter what that cost may be. We have a laboratory program, and so if you are uninsured, you are able to receive laboratory testing, same as an insured patient, at no cost to you. Now, this requires money. Right, and so when we look at the federal landscape and we look at changes in funding and grants that no longer become available to us for one reason or another, we may come to a point where we have to start making those decisions, like the questions you've been asking about how do you prioritize what services you're able to offer. But as it stands now, I want to reassure everyone that's in this room, and hopefully you could pass this message on, and we have to do better with messaging, is that federally qualified health centers are thinking about the same question that you just asked, and we're coming up with solutions. We're being innovative, we're being creative, we're working with leadership to push policy to address those issues every single day.
Yeah, no one should have to die with just not having the information, right? Especially if the healthcare is available to them. Thank you so much. I'd like everyone to give a round of applause to our panelists who are here now and who were up before. We have lunch that's waiting for you. After lunch, we have some presentations for you. We have some tea, and then we have another panel that's going to be more clinical. So thank you all so much. Okay. She wants to take some pictures.
Do I start it with this? Is it, or it plays from here? Oh, it's like, okay. That's good. All right. Is it all set? Yeah. Okay. Okay, excellent. Sorry for the little delay. So, women's health is one of the unique fields in medicine where we often have more than one patient in one body at one time. Although I think some psychiatrists might argue that they also do. Today, I wanted to talk about something that Dr. Clark brought up first, I believe, this morning, and it was about culturally competent care. And we've heard from the policy experts, from the legislators and whatnot. Today, I want to talk about at the point of care where we take care, we see the patient, what are things that we can do, we should do, and we should be incorporating into caring for our patients. So I am an OBGYN. Some of you will recognize this site right here, 1150 Springfield Avenue. Back in the pre-COVID times and during COVID, I spent 2 years working here, taking care of patients. So I know NCHC very well. Yeah. Yep. And then afterwards, I went on and I did a specialization in then high-risk pregnancy, which is what I do now. And I work at Newark Beth Israel. And we take care of a lot of your patients, see them all the time. So it's a great working relationship we have going. So the fact that we're all here means that you value FQHCs as much as I do. And I just want to give a quick snapshot. This is data that was published last year, but it's from 2023 data. And this is about New Jersey in general. So these are all of the services provided in New Jersey by the FQHCs. And you can see that over 600,000 patients were treated during that 1 year alone. So a substantial amount of our population. And that included over 28,000, they use the term homeless or patients, and encompasses over 2,000 clinical professionals. Lots of services, over 1.5 million medical visits were performed during that time. Everything from substance abuse, dental, mental health, like at the center I worked at 1150, one-stop shop for everything. It was great. The vast majority of the patients in Jersey that visit the FQHCs are of Medicaid. About 79% belong to or identified as being in a racial or ethnic minority, with 52% Hispanic or Latin descent, and about 44% their preferred language was one other than English. As many of you know, I oftentimes spend my entire day speaking Spanish to patients or using the language line for Haitian Creole and other languages. So they're very vital tools, having the interpreters. And this is just showing the revenue. Oh, sorry. The vast majority are so even though the vast majority are Medicaid, one key thing I wanted to highlight here is if the two bars, the biggest thing to take away is that the amount spent per patient on FQHCs in New Jersey is actually more cost effective than traditional outpatient visits at other doctor's services, that the amount spent per patient. So that's, to me, very significant. Over the course of the day, multiple people have talked about the push for universal health care. This would be something advocating for that, especially when you link this to clinical outcomes. So I just wanted to put up a clinical scenario. So let's just say I have a patient comes in, they have uncontrolled diabetes, and they repeatedly miss appointments, they decline to use insulin. We see this all the time. So your initial interpretation might be, oh, this is a non-compliant patient, this patient's being difficult. Why that? Okay. Sorry, my slides are all off. However, part of our job, especially as practitioners, everything from the medical assistant who first checks in the patient to the secretaries that are taking their intake information to us when we finally see them in person, are trying to get a better picture and see what's going on. Is this a patient due to limited English proficiency? Are they having other family obligations where they can't make the visits? Is it transportation, work issues, which that's one of the great things with Beth and NCHC, having the Uber rides has been amazing for our patients. And then is it housing instability as well? So standard of care in medicine is pretty much considered what would a competent physician do in the given circumstances. And it's more kind of a legal term to say what is standard of care. But it involves more than just guidelines and following a protocol. It includes your communication with the patients, shared decision making. It's a huge buzzword and implementation thing that we're really hammering down into the medical students right now, to bond with the patient, get that, build the trust, build the relationship, and take into account their beliefs, systems, and desires. And then recognizing barriers to care are all parts of standard of care for medicine these days. And so, obviously, real life is more complicated than guidelines. All of the barriers that we had mentioned today and previously. So today, the standard of care should be addressing all of these issues as they come up and as they're needed, and screening for them as well, because how can you possibly take care of a patient if they can't afford their medicine or they can't afford their food? So it's the whole general picture, not just treating a disease. It's seeing the person as like the complete picture and treating them as such. Then, in the melting pot of New Jersey, especially in Newark, cultural differences are huge. How many patients have you met that have different belief systems about how they had their miscarriage? That, oh, someone must have put a hex on me, or someone did some voodoo against me. And it's a true belief. It's a valid belief that you have to accept, because that's what their tradition, that's what they might have been brought up and believe. And so it's really important to take into account what cultural differences there are and try to make your approach tailored for that patient. And it's been shown by having cultural humility, by having a cultural respect and trying to identify the needs. It improves the trust with the patient, improves their compliance with medication, and also and thereby improves your outcomes. And so that goes from everything from health stigma, mental health stigma, preference of traditional remedies, family-centered medical decisions, religious concerns, and then big one, especially historical mistrust in the healthcare system. One thing I always love to do if I'm meeting a patient for the first time, especially if they speak Creole, is I'll walk in the room and I'll say, bonsoir, c'est Dr. Yusla, désolé, ça m'a parlé tout petit Creole. And the vast majority will do what you guys did. You get a big smile or a laugh. And they'll be like, oh, white boy speaks Creole, you know? And especially the little old ladies, they love it. I mean, they're like, you're like best friends for the rest of the visit. Doesn't matter what it is, you see the tension level come down. And yeah. And I do speak a tiny bit of Creole, some more OB, labor and delivery Creole than anything else. But yeah. So communication challenges are always huge. And just because they speak English, we don't know the proficiency. The average, they say about a third to 40% of Americans read at a 6th grade level, which is why all the time that we create patient information material, it's written usually at a 6th to 7th grade level with that in mind, because just because English is their first language doesn't mean that they finished schooling. So it can be really hard to gauge, do they actually understand what I'm talking about? And using terms that are not purely medical is really important. Asking, this thing likes to jump ahead. Wow, I guess I wasn't going fast enough. Avoid relying on, do you understand? Questions like that. I'd like to use, and we try to get people to use the teach back method, where you say, okay, can you explain to me in your own words, what did I just explain to you? Especially if it's something complex. If I have a patient who has a complex fetal anomaly, or let's say a serious heart issue with their baby, and I draw diagrams, I show them all everything, they might be just so shocked from it that they can't really respond to me and tell me, what did I say? And so I like to have them teach back methods. Say, okay, well, what did you learn from this in your own words? What did you take away from this? What did you not get from this, to try to fill the gaps and to try to give a better counseling session. And that can be really powerful. And especially even with interpreters, it can be very hard. I'm sure all of you have used interpreters before. You speak for 4 sentences in a row and they say 5 or 6 words, and that's it. And you're like, did you tell them what I said? And I don't speak that. If I don't speak that language, how do I know my message was getting conveyed, or even appropriately? But yes, but whenever possible, interpreters are definitely very, very helpful. So open-ended questions are great too. I know we're all limited time slots. Of when I was a general OB/GYN, you had between 7 and 10 minutes to see each patient. You don't really have a lot of time to have these long, lengthy-winded conversations with patients, but still using open-ended questions can help to let the patient express themselves and get what their true issue, the true reason for them being there is. So that also goes with when patients decline care. Man, this thing is, okay. So we always have patients, they refuse vaccines, procedures, hospitalizations, they leave against medical advice. And the standard of care is not trying to force compliance on anyone. It really should be trying to figure out what is the motivation. Why do you have to leave? Is it that you don't have childcare at home? Is it because of some other obligation that you can't be there? And so that comes down to our responsibility to assess their decision-making capability, to explain the risks and benefits, understand patient concerns, and then trying to preserve some trust with the patient. So that way, even if they say no, 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 you want that patient to come back in the future and see you again. You don't want to just say, oh, you're not going to do what I say, and fight them over that and make things worse, because then they won't come back to you, and who knows if they'll seek care in the future with someone else. So it's really important for patients to have that positive encounter with you, regardless of what the scenario is. And that goes down to the difference between equity and equality. I love this little picture on the bottom here between the two. As you can see there, that the equality was everyone gets the same, so everyone gets the same instructions. Let's say you come to my office, every single one here has high blood pressure, so I'm just gonna give every single one of you the same exact pill, and I'm gonna give all of you the same reading material, bye. Okay, so that's my equality. Equity, that's care adapted so that everyone can have a positive outcome at the end. So like, equity is going to be, I figure out what language do you speak, what's your comprehension level, how much information do you need? Do you want a whole pamphlet on everything about the disease, or you just want a quick bullet points of it? And then, okay, your blood pressure is higher than this person's, than that person's, and that person's. Let's tailor the medication so that everyone has the same outcomes in the end. And so some of the examples with this are your translated materials, the flexible clinic scheduling, as we mentioned before, 7:30 a.m. mammogram or late nighttime office visits, transportation support, huge, huge in our community. Community health workers, doulas, all of the ancillary staff who make what we do run are vital for us. And then simplified treatment plans if needed, based on the patient and their characteristics. Obviously, we're going to have system-level challenges to work through. There's never-ending supply of short staff. Any floor, any unit, anywhere you work faces that. Time pressure, your limited specialty referrals can be an issue. Get an ultrasound done or a mammogram scheduled can sometimes be a barrier. And then not to mention insurance, which I know many people have said already, but if we had universal health care, it wouldn't be a problem. So my main thoughts, my main takeaway is that the standard of care is not just applying medical knowledge, it's not just protocols, and although we do use evidence-based medicine, it's taking the patient as a whole into the picture and tailoring your management and counseling based on the individual person, and in a compassionate, ethical, and realistic manner. And in our diverse community, to be clinically excellent, you can't just be proficient at your job as far as the medicine or the surgery or the procedures. It takes cultural humility, it takes being a real human. And making that bond and connecting with the patient. And that's, if the patient has a good experience, they're going to come back to you, they're going to seek care in the future, they're going to be more compliant, and you'll have better patient outcomes. So they actually say that, I'm sure you've read, that patients who are cared for by a female doctor have better outcomes and they live longer than those cared for by a male. Have you read those surveys? For multiple factors and whatnot. And it should also be positive that this, 6th year running, there were more females admitted to medical school than males for the 6th year in a row. So the physician population workforce is going to be drastically changing, and it has been for many, many years in a good way, especially if women provide better care. I have to, you know. Yeah, any questions on any of that? Oh, sure.
You mentioned as far as, well, I call it cultural sensitivity. I run a nonprofit, and our mission is to end child sexual abuse and gender-based violence. So we give trainings to to healthcare workers on how to be culturally sensitive to the population that may have been abused because they respond differently based on their background, their religion, so on and so forth. So my question is, as far as your experience as an OBGYN, I'm sure you come across women who are survivors or may still be in their situations. How have you seen, if you have recognized, how that plays out differently compared to other healthcare challenges?
Yeah, no, great question. So it might be, as a male, I either kind of get like a splitting thing where either patients are very hesitant to talk about anything to me as far as past sexual violence, or they're completely open and they're eager to talk about it. Oftentimes though, our patients come to us with multiple types of trauma, whether it be sexual or environmental or living in unsafe neighborhoods. And there's multiple issues at once that sort of are directing their response to certain things. Like oftentimes I have patients that just act out and they get aggressive or abusive towards the staff and whatnot, and they might just be basically triggered by something that was said or a look someone gave them or something that brought them back to whatever that original trauma was. And so from my standpoint, that's one thing I immediately think of if there's a patient who's in office and being very loud or aggressive or comes in drunk or on drugs or whatnot, that's their coping mechanism to some previous trauma, and it really helps to de-escalate the situation and not try to provoke them and figure out why was this because you were raped when you were young? Not, obviously not anything like that. But if we can get some clues into why, and that can also, I've had some patients over the years that were very, very difficult, but then ended up like loving me and would come and ask for me because I took the minute to sit down. Okay, let's go sit and talk and just relax and figure out what's going on and solve the problem. Because oftentimes it wasn't that I've been waiting for 15 minutes in this chair and I'm angry about that. It's because I took 2 buses to get here. One was late. Then I got rained on, and then multiple layers of levels of things. So, yeah. Okay. All right. Well, thank you for inviting me to. Okay, thanks. What's that? I have to leave by 2:15. Oh crap. Oh.
He was supposed to join us for the panel, but he just said that he's going to be leaving, so he won't be with us for the panel. So this is your last opportunity to see him. So Dr. Stella, thank you so much. Thank you so much. Dr. Patrick Anderson is the next person who will be giving us a presentation this afternoon. Here he comes. Okay.
Good afternoon. Hope I don't bore you. Dr. Gisela and I, there's quite a bit of overlap in the conversation. And the goal of all this is to, how can we address patients' compliance through communication? Oftentimes we talk about barriers to healthcare, even when the services are available, but the issue surrounds how the messages get passed down to patients and their support. I'm a GYN oncologist. I feel like I've been in the neighborhood for 100 years. I've been working with Newark community for a very long time, and it's been a strong and excellent partnership. So when it comes to delivering cancer care, You know, we're delivering one of those diagnoses that, you know, relative to other diagnoses, when folks get an MI or a stroke, folks say it's God's will, but when you get cancer, it's a catastrophe. Well, I'm here to tell you that if you believe in the science, there's so much information, and the field is moving so quickly. So cancer care of today is not the same of yesteryear. So delivering the diagnosis, and how do we balance the truth with compassion while giving hope, and how do we do it from the perspective of the provider? Because at the end of the day, for me, outcome is how strong is the relationship I have with the patient and how I engage them enough to increase compliance. So communicating a diagnosis, a treatment plan effectively is, you know, one of the most clinically important skills that anyone could have. And goals of effective communication is to really provide accurate information, preserve hope, because again, we're not talking about taking someone through a pregnancy, which at the outset from start to finish, you're expected to have a good outcome. But with respect to cancer, everyone ultimately thinks the outcome is going to be bad, and that's not always true. In fact, the majority of time, we've gotten to the point where we convince patients that we may not cure your disease, but you will live a good quality of life for a very long time. Right? So provide accurate information, preserve hope, support decision-making, build trust, and recognize the emotional impact on the families and on the patient. Last year when I was here, the talk I had was financial toxicity in cancer care. And it's probably as important, more important now than it is then, given all the changes that and policies that are occurring. So some core principles before you meet with a patient, and this can be applied broadly no matter what specialty of medicine you practice or what the circumstance is. You must be prepared for the conversation. From my vantage point, you know, you review the pathology, review the slides, convince yourself that the diagnosis is accurate. Malvika, I take her up to pathology all the time just to go look at slides, right? Review imaging, understand staging, and give treatment options beforehand. Also anticipate some questions. Is it curable? Because like I said, anything else is God's will. If it's cancer, it's catastrophe, right? But that's not necessarily true. How long do I have? I often tell the patient, you have as much time as you need, right? And you encourage them, right? What are my options? Be very clear. Ensure privacy and enough uninterrupted time to have a discussion with patients. Oftentimes, you know, we're multitasking, and, you know, with electronic medical records, we're typing, and we're really not looking at the patient. And if you're not careful, your back is to the patients the whole time. The only person I excuse that was Miles Davis, because I love it when his horn is to the wall and his back is to me, because then I see his expression, right? But you must ensure privacy and enough uninterrupted time, right? One of the things that happens in medicine is, you know, we tend to conduct business in open air, right? Sometimes in same-day surgery, different services getting consent, and all of a sudden you realize your neighbor smoked weed last night. They don't want you to know that. So ensure there's privacy. And when you sit and communicate with patients, let them know you care, right? You don't sit with them with your jacket on. You don't sit with them with your backpack on your shoulder ready to go, right? You sit eye to eye and communicate directly with them. So oftentimes when we work, because we're so busy, you know, a framework is always good, right? And it allows you to be consistent structurally and with the information that you disseminate, right? And one such protocol I like is the SPIKE protocol, which is one of the most widely used in oncology. And the S stands for setting up the interview. We spoke briefly about that. Private environment, include family and support persons, minimize interruption, and you sit rather than stand. Put your backpack away, take your jacket off, and pay attention to the patient, right? Let them know that at this point in time, they're the most important person, right? P is assess perception, right? So you have to kind of read body languages, right? And that comes with experience. I had an 83-year-old patient who said she was a pastor and she communicates well. And when I said, I got your test result back, we can talk about it now or we can wait for your family. She said, listen, I communicate well. I'll tell my daughters. So I told her. 15 minutes later, I get a call from the hospital administrator. This patient is very upset and wants to fire you. Right? So it's shocking, but you have to figure out the cues, and body language is important, right? So assess perception, determine what the patient already understands. For example, tell me what you understand about the test so far. What have other doctors told you? Oftentimes, patients come to me, they already have a diagnosis. So I ask them directly, tell them directly who I am, what I do, and ask them if they understand why they're here to see me. Okay? And this often prevents overwhelming the patients and identify misconceptions, right? Again, obtain invitation. Ask how much details they want to know. For example, would you like me to go through all the details? Some patients prefer broad information rather than overwhelming them with specifics, right? Oftentimes, they don't want to know what PD-L1 means. They just want to know if the medication works, right? And patients differ greatly with information preference. Also, they differ greatly based on education, based on understanding, and the source of their own information, right? What's the term we use? Conspiracy theorists? Yeah. So the long and short of it is you meet people where they are. K, give knowledge. Deliver information clearly and in small segments. Some techniques, avoid jargons, right? Use short sentences, right? Pause frequently, because you give the perception that you're listening, you're paying attention, right? Warn before bad news. For example, unfortunately, the biopsy shows this. I am afraid, right? Make yourself part of their whole emotional spectrum, right? Then you pause some more, and you can use some chuck and check, I call it. Give small pieces of information and ask, does that make sense to you, right? You have to be careful because sometimes you can come off as being condescending. But again, it's all a part of your perception of and reading the body language. E, address emotion with empathy. And if not for anything, empathy in medicine is probably one of the best tools you can have in your tool set, in spite of the rigors of communicating and the relationship you may have with patient. So silence is golden, always, right? You listen. Some common emotional response when you get a news that's potentially catastrophic is shock, anger, fear, denial, guilt. I have a patient, when I told her, what her diagnosis was, she said, I'm not owning that. How am I supposed to respond? You stop, you listen, and you say, well, what does that mean to you, right? Use empathetic statement. I can see this is overwhelming. Anyone in your position would find this difficult. I wish the news was different, all right? We always wish the news was better, right? I'm sorry about the yellow, but this is another structure that I like to use when addressing emotion with empathy, and it's a nurse's framework. N is named emotion. You seem frightened. Understand. I understand why this feels scary. Respect. You have handled a lot already. Keep them engaged in the process. S, support. We'll get through this together. And some of the simple things like getting it together is like Uber Health, right? Access people have different difficulty with transportation. You let them know how we can support them, right? And E is explore. Tell me what worries you most, right? Because again, last year when we talk about financial toxicity, oftentimes barrier to healthcare is people sacrifice doctor's visit to go to work, right? And that's just a reality, right? Then S, as part of the SPIKE framework, is strategy and summary. End with a clear plan. And you don't have to overwhelm the patient with rigor. Just be clear about the plan. Patients often remember structure better than detail, You know, I find that to be very true. Okay? And for example, the next step is a PET imaging and the meaning with a radiology and a meeting with radiation oncology. And then you explain to them what PET imaging is. You explain to them how the radiation oncologist will impact their treatment, right? Our goal is to cure, right? Set a goal. You know, don't make it unrealistic, but set a goal. And what I mean by that is, initially when we talk about preparing and we talk about stage, if you're talking to someone about stage 4 disease, that's a different conversation than if you're having a conversation about early stage disease, right? Or our goal is to control the cancer and maintain quality of life. Part of cancer care is survivorship, right? Part of survivorship is quality of life. What does quality of life mean? Ability to go to the club and dance at 70s night, ability to conceive, because many of our patients are patients in the young reproductive age group, right? And you provide written information and scale the information based on the assumption that the patient will understand everything from the ground up. So you start on the ground level and you increase the complexity of your explanation as you understand who the patient is and what their support crew is like. Follow-up appointment is key. Don't ever let a patient leave your office without a follow-up appointment, okay? As important as a follow-up appointment is a contact pathway. You must always be available, whatever that means to you, okay? And you don't have to be the one. They just need to know that you're part of the process, whether it's you directly, whether it's your nurse, whether it's your nurse navigator, or just an administrator. Some other helpful techniques is, they call it ask, tell, ask. Ask what they understand. Tell information clearly. Ask for a response. For example, what is your sense of how serious this is? This cancer is treatable but not curable. Patients can be accepting of that. They don't like surprises. What thoughts are going through your mind hearing that? Use ranges rather than specifics, right? So use range rather than exact timeline. Avoid false perception, okay? Instead, you have 6 months as opposed to, instead of saying 6 months, you give them a range, 6 months to a year, right? People in this situation often live many months to a few years. Give a range, right? Some other helpful hints. Balance hope and realism. Hope should not disappear even when cure is not possible, right? Because then the lack of cure translates into quality of life. It translates into symptom control. It translates into just planning for anniversaries, just planning for milestones. Give them some chance to maintain some independence, even if it just means being part of their own decision making, right? Oftentimes the children come in and they don't want to, say, Mom, we'll handle this. Mom or Dad needs to be part of the conversation, right? And in spite of their symptoms and disability, have them have some positive and meaningful experiences, right? If they're able to come out in a wheelchair, take them to see Alvin Haley. They were just here last weekend, right? So while we may not be able to cure the cancer, we have treatments that can help control it and help you feel better. And this is meaningful to me because one of the things, and this is often as people of color, we have trust or mistrust in the healthcare system. Clinical trials is as important as direct treatment, right? Because it helps you feel part of the scientific process, right? So now you can't do anything for me. What can I contribute, right? They can be part of a clinical trial, varying stages, whether it's a toxicity trial or a treatment comparison trial, right? And oftentimes that's very valuable to folks because instead of sitting at home waiting for that final day, they feel, as part of a process. All right. Present some clear options. So for each option, discuss a goal, whether it's curative, disease control, or palliation. Palliation simply means symptom control. Outline some benefits and some risks right? Risk is important because one of the biggest barriers to cancer treatment is management of side effects, right? And also misconception. Well, it's going to kill my normal cells. Well, the cancer will kill your normal cells as well. But you don't want to be a flip about your response, right? You want to be very sensitive to the response. You want to talk about side effects that they can expect and talk about alternative and impact on quality of life. Avoid information overload. Right? Patients in distress retain little information, all right? And that's important. Some helpful strategies: prioritize 2 to 3 major points at a time, repeat key information, use diagrams or written summaries, and schedule follow-up conversations. Some of us call it closing the loop, right? Yeah. Sometimes emotions will escalate. Do not rush into more facts when, you know, the environment is heated, right? Instead, pause, acknowledge the emotion, and allow for silence. Again, silence can be therapeutic. All right, and I'll be wrapping it up soon. Right? When patients ask directly, am I going to die? A possible response could be, this is a serious cancer, and it's something that can shorten your life. Don't tell them they're going to die. Just tell them it'll shorten your life, right? Give them a chance to evaluate what that means, right? At the same time, you do have some treatment, right? Give them some hope. And when there's non-disclosure issues, oftentimes we don't want mom and dad to know their diagnosis. For us, that's a conundrum, right? But there are some cultural issues that might exist, and we need to respect that, right? Some family members may say, do not tell the patient it's cancer. A useful response would be, I understand you want to protect them. I also want to understand how much information the patient themselves may want to know. And this respects some cultural elements. And some things you can avoid, there's nothing more we can do. Never say that. Because even if it's just a pill to make them have a good night's sleep, that's something, right? You need to stay positive. Excessive statistic early in the conversation, you should avoid those. Premature reassurances is never good, right? But instead, there are still ways we can help. We'll continue to focus on your comfort and your goals, all right? Make the patient the centerpiece of the conversation. We talk about some of this. You sit down, you maintain appropriate eye contact, avoid typing while you're having these discussions. Lean forward, show the patients you're engaged. Use calm tone and pacing. Allow pause. Patients often remember the demeanor more than the exact words. All right, some definition, curative intent. You emphasize the goal of cure versus goal of care. When there's advanced disease, again, it becomes now goal of care and quality of life, symptom management, and shared decision making. And when it comes to end-of-life discussion, the best approach is start having the conversation early, introduce the elements gradually, rather than trying to introduce it during a time of crisis. Prioritize patients' goals. You need to have some acceptable quality of life, even if it's a simply pain control. And explain what hospice means, right? It's not a bad word, okay? It's not a bad word. All right. So these are some sites where you can go for information: the American Society of Clinical Oncology, the National Cancer Committee Network Guidelines, the Vita Talk Communication Framework, and Serious Talk Conversation Guides. Right. So I'm going to summarize by saying, you know, I often prescribe what I call AAA, right? And I wish AAA means Anderson, 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 but it's not. It really is, when it comes to serious communication, you need to be affable. You may not get everyone to like you, but just have them trust you, right? You need to be available, whether it's you directly or someone from your team, right? When I call NCHC, I don't necessarily want to speak to Dr. Clark, but if she answers the phone, I'm happy, right? And then you have to be academic, right? You have to know your craft, right? And if you can align all three elements, then you'll be very impactful when communicating with patients. That's it.
Thank you so much, Dr. Anderson. And of course, you're not going to go away, are you? Because you're on the panel. And we're going to do our clinical panel now. In the interest of time, we're going to just get right to it. I'm going to introduce everyone to come up. I'm not going to ask them to introduce themselves. I'm going to try to save some time here for everyone. Of course, Dr. Patrick Anderson, who you just heard from, who is a GYN oncologist at the Cohen Cancer Center. Dr. Lisa Gittens-Williams, Director of Obstetrics and Quality and Safety Division of Maternal Fetal Medicine at Rutgers Medical School. And Dr. Natalie Roche, the Associate Professor of Obstetrics, Gynecology, and Reproductive Health at Rutgers Medical School as well. All of you, please join us now for our clinical presentation, or not presentation, but panel now. Thank you so much.
Turn this on. I'm in charge of GYN at University Hospital. So she's in charge of the OB service. I'm in charge of GYN. So he's cancer, OB, benign GYN.
Here we go. All right. Let's talk about black women in New Jersey who are about 40% more likely to die from breast cancer compared to white women, often due to later diagnosis. What specific community outreach initiatives are in place to close the gap?
So there are several. Pardon me. There are several. Most of our institutions, whether it's Rutgers or the Barnabas system, we have symposiums like this. We have Women's Health Day, and we have screening endeavors, community outreach, where we have free mammograms. But in all of our respective practices, so I may see a patient for cervical cancer. I still pay attention to milestones, right? Did you have your mammogram? You're 40 years old. Same thing should be happening in the primary care elements and also in regular benign GYN encounters. So one, the key is milestones. The other thing is with community outreach, for example, OB Healthy during our symposium. Every month throughout the year, there's a label, right? Cervical Cancer Month, Breast Cancer Month. So during those time frames, when we all have our outreach, I'm with Dr. Bay and OB Healthy, we pay attention to those scheduling, and we encourage patients to get screening. Another important part of it is to have the expertise in the community to manage this, right? Because oftentimes we identify and we create what we call centers of excellence, but we need to understand demographics. I can tell you, patients from Elizabeth don't like to leave their zip code. So they don't care if you have a center of excellence in Newark. They're not coming to Newark, right? So you need to flip the switch on them, right? Bring the medicine, bring the service line to them. So when I drive down the street and I see a sign that says Rutgers Health, then I can appreciate that. When I drive down the street away from Newark Beth Israel or St. Barnabas and I see a sign that says Barnabas Health, that's meaningful. It's because we're bringing the service to the community and not forcing the community to come to us.
Wonderful. You wanted to chime in on that.
I always have something to say. Well, one of the big problems we're going to have is about insurance issues, because some of the free programs that we have disappeared over the last year where people could get a free mammogram. So this is going to be one of the challenges. It's going to be an increasing challenge as people get thrown off of Medicaid, which is on the horizon. And so this lack of insurance business is a hard one. We have to educate our patients that when they see their mammogram results, and many times they will, if it says dense breast, they need a breast ultrasound. And if you are a brown or a Spanish person, they may not order it for you, and the patients better know how to advocate for themselves. Where's my ultrasound order, okay? And then the other thing is that they have a family history. The black and brown and Spanish people are less likely to get any kind of genetic testing. And therefore their family members who would otherwise need to be screened and screened earlier will not have that piece of information. So the people who have the breast cancer themselves have to ask about genetic screening so that their family members can be aware that they're at increased risk.
And then I'll just add, as the pregnancy expert, pregnant women can have breast cancer. And so whenever someone comes for prenatal care, I make sure that I ask them about their family history of cancer. Because if they have a mother or a sister that had breast cancer, they may need screening, they may need early screening, and they may need that genetic screening. So just like we screening for sickle cell disease and Tay-Sachs and other genetic disorders, we do have to ask that history. So if any of you have a family member, sister, cousin, yourself getting prenatal care, make sure that they're asking that genetic history. And it should include cancer, colon cancer, breast cancer, ovarian cancer. That's on my list.
I actually did a story once with a woman who was pregnant and had cancer and had to get through that. And I mean, it just didn't seem like anything more devastating to have to try to save your life and worried about your baby. And, you know, what do you do in a circumstance like that? Just really, really sad. She survived. She did survive.
If I might add,
Yeah.
The use of technology, and to address what both Dr. Gittens and Dr. Roach was saying, is the electronic medical records, if used properly, you should input risk factors, right? And that risk factors may not pertain directly to you, but a family history. It's an effort to do a risk assessment, and oftentimes, as soon as you open the patient's chart, some cues pop up in the storyboard. But again, like everything else, it has to be used appropriately. So with each encounter, do we really have enough time to put in all the data that's required, right? And there are some techniques that are used. Oftentimes you get notification to pre-register before you walk through the door from your phone. And they can ask those specific questions. And that question gets compiled in the database and it pops up. So those are some of the elements that are occurring, but we still need to pay attention.
All right, this next question is for anyone who would like to answer it. With the 2026 HRSA and ACS guidelines emphasizing primary HPV testing every 5 years for women 30 to 65, how are New Jersey providers transitioning away from annual pap smears? And tell the audience what HRSA and ACS actually stand for, if they don't know.
Yeah. So ACS, American Cancer Society, there's been a push for a very long time to replace the pap smear with HPV testing. And I think now there is a home kit that one can use to collect sample, similar to other cancer screening like the Cologuard. Similar idea. But again, patient has to be educated as to how to use it and use it properly. And then the piece that needs to be addressed is where does the information go and who disseminates the information, all right? So the goal of screening, so just remember this is screening, not making diagnosis, right? And the goal of screening is to identify who's at risk, because eventually that patient needs to have a face-to-face with one of us, right? So that's the goal of screening. And for it to be effective, it has to be very specific and be very sensitive. It needs to be reproducible and it needs to be cheap. And that's what these diagnostic kits are meant to do.
Dr. Gittens-Williams, data shows that in New Jersey, Black mothers are nearly twice as likely to experience infant mortality, right? We've talked about that many times. What can be done to address the issue leading to this statistics, and what is being done to kind of help solve this problem? It's a huge, huge problem that we're having in communities.
So it's not only infant mortality, but it's also maternal mortality. So the rate of stillbirth among Black women is higher than the rate of stillbirth among white women and Hispanic women. And as we know, in New Jersey, maternal mortality is 7 times the rate for Black women than white women. So this is a large problem. And I had a colleague that said, is New Jersey more racist than other states? I'll leave that to you all. But some of the historical things in New Jersey, we talk about redlining, the way that communities have been set up historically, where people live, where they were and are allowed to live, educational levels. It's always shocking to me. There's a report that's publicly available. It's the New Jersey Maternity Report Card. I have to thank the Murphy administration for starting it, putting out data from every birthing hospital. And it's shocking to me, because I work in Newark, that in the city of Newark, the rate of education for patients that deliver there, many patients are just high school graduates or didn't attend any high school. St. Barnabas is 9 miles away, 15 minutes, and the rate of education, most patients have a college degree or a graduate degree. So would you not expect differences in maternal mortality and resources? So, what is being done? What is being done are addressing things at the system level, what can be done in the hospital to reduce bias, what can be done to improve treatment, bias at the door, checking your bias at the door, and then what can be done in the community to help the community become aware that these differences exist. Demanding treatment. So when you go to the emergency room or you go see your doctor and you're getting dismissed, what do Black women do to make sure that they're getting adequate care? And then how do we follow up on our newborns? One of the things that's happening at the level of the community is home visiting nurse services, so that women who go home with their newborns get that newborn checked, so there's not what we call a crib death or sudden infant death syndrome at home. Getting your infant checked by someone at home to make sure that you have adequate pediatric care. Those are some of the things that we can do.
Excellent. Dr. Roche, how can we better integrate doulas and community health workers into the traditional maternity care team?
Well, luckily they're paying doulas now, which is a big advance. And I think most of the maternity hospitals have been incorporating doulas. It's always a slow go because doulas have not, people are not familiar with them. I'm getting ready to end my career, and I worked with doulas back in the 80s and the 90s. But somehow in New Jersey, this looks like it's a new phenomenon. But doulas need to be, the patients need to know that they're available, that Medicaid will pay for them. They should be seeking them out. It really does help to have that extra layer of advocacy. Because for our kind of patients, the whole issue about trying to have effective communication with the healthcare team is always a problem, all right? People need to be able to advocate for themselves, but when you're in a very vulnerable position like being in labor, it's a little hard to be able to manage to pull that off. So having family members helps to a certain degree, but they don't have necessarily all of the information to be the best advocates for people in labor, and the doula is a really great resource, all right? So we really do want to encourage the patients to use doulas. They really do improve the outcome for patients, and the doula is involved in the prenatal portion, the delivery, and they also, in some groups, actually follow the patient postpartum and also offer some support at that phase.
It's just great that they're being embraced now more and more, and like you said, getting paid. That's very important. It's important. Dr. Anderson, or did you want to go ahead?
I just wanted to say that culturally, in other cultures around the world, childbirth is a community process. Women deliver at home, they deliver in birthing centers. We have medicalized childbirth and made it such that women then labor by themselves, flat on their back, and we really are trying to change that. So childbirth really it should go back to being a community process, and that's where doulas and midwives and other parts of the birthing team come into play. That's just something that has been typically done in the United States. And it's because of the way, if you look at historically, women, midwives delivered babies, then OBGYNs came, and then OBGYNs were white men, and the whole system has to flip, and it has to incorporate a diverse population, giving people different types of birthing options. So doulas are part of that.
Yeah, excellent. Dr. Anderson, what is the current guidance for cervical cancer screening in patients who have undergone a hysterectomy within the New Jersey healthcare systems? And what specific barriers to cervical cancer screening are most prevalent among non-Hispanic, Asian, and Hispanic women in New Jersey, and how can we mitigate them?
So that is a couple of questions rolled in one. So specifically, screening in women who've had hysterectomy. It depends on the type of hysterectomies, right? So a subtotal hysterectomy means the cervix is still there. So those patients need to be encouraged to follow the guidelines of patients without a hysterectomy, right? And what that means is for patients who have HPV or HPV-related illnesses, those patients could get annual screening or managed based on their current diagnosis. So do they have positive high-risk HPV, specifically the 16, 18, 45 as one of the high-risk ones that causes cancer. With the low-risk HPV, the guidelines are a little bit different. So in that case, you follow those patients based on your current diagnosis, whether that diagnosis is what's revealed on prior pap smear or on biopsies. In patients who have their hysterectomies where the cervix is removed, just remember the cervix and the vagina is connected. So if they have their surgery because of HPV-related illness or some sort of a malignant or pre-malignant process, then the guidelines for the average patient does not exist, right? You follow those patients again, similar to their history and their current biopsies, right? So some of those patients, if they have active dysplasia, you may want to follow those patients every 3 months to every 6 months. In patients who have surgery for benign indication, non-cancerous indications, then, it's, again, if they've never had HPV-related illnesses, we don't do pap smears after 65, right? But I do still encourage. Some patients interpret that as you don't need a pelvic exam. Well, if you have any kind of symptoms, urinary frequency, constipation, any of that, you still need to come in for a pelvic exam. You won't necessarily have a pap test done.
So the whole thing, and this is totally off script, but the whole thing about over 65, does it mean you're over 65, if you get any care, it's not going to help you? I mean, what's behind that whole over 65 and you stop getting certain tests?
I think it relates to the alacrity and the speed at which disease processes develop, right? So we often know that if you don't have HPV-related illnesses prior to the age of 65, what's been shown by data is for you to start developing HPV-related changes, the inoculation usually happens 10 to 15 years prior, right? So now you're at 65, you've never had those issues. If you develop HPV, if you get inoculated at 65 or 70, you'll be 75 or 80 before you start having some of those changes. Right?
Well, as a 70-year-old woman, I have to take some, issue with this, all right? All right. So the data is global data.
Right.
And the baby boomers, I always say we're the sex generation. Had sex early, kept on having sex, and they're going to keep on having sex all the way to old age. 90-year-olds, what percentage of 90-year-olds are still having sex?
Give a number.
10%, right?
Right.
So they still, sexually active. So the reality is that there are plenty of women in their 60s and 70s who may get new sex partners and may get HPV infected. And the average age of death for a woman is mid-80s, and then many people, one of the fastest growing groups is the people in their 90s and going into 100. So you got to pay, I object to some of this no screening. You got to take a history.
That's why I asked the question.
If the woman
I
is
just thought it was very
65 and got a new
strange.
sex partner, mother lived to be 100, please do not
Yeah.
stop screening that woman,
It
all
seems
right?
like something needs to change with that. Because people are
So-
living longer and all everything.
So
else.
you
same is
have
true
to
for breast
actually,
cancer.
you have to act,
Screening.
even colon cancer. So you have to actually look at the likelihood, the medical illnesses, the likelihood of longevity, and the sexual behavior before you make a decision about ending pap smears.
Right. I totally agree. I don't stop screening. I do not
okay.
subscribe to any of that, and not colon cancer, not osteoporosis, not pap tests, not breast cancer.
Okay. Yeah. Okay. Well, good. So that means you guys can make your own decisions in the office. You don't have to. These are the guidelines, and this is what we have to
They
do, kind of thing.
are
That's good.
Recommendations.
Recommendations.
But if your provider tells you, or your mother, that she doesn't need a mammogram because she's 70 and she's a good 70 and your great grandmother lived till 100, get your mother a mammogram.
Okay. All right. Excellent. All right. What are the best strategies to ensure that nurses and physicians leave their biases at the door and treat every patient with dignity? And you can all take that, or one of you can address that.
You know, I'll start. I stand in front of the mirror because we all have our own biases, right? So before I start to tell other folks and educate other folks how to behave, I must first recognize some of my own struggles, right? So, for example, you know, biases could be influenced by anything, right? I mean, your personal history of cancer. So then what? I don't follow those guidelines. I screen. I have a close relative who died at 58 from breast cancer. So I don't stop screening, right? By the same token, my grandmothers all of them lived to be almost 100 or over 100, and they were in good health, right? So I'm not gonna stop screening them, right? Prostate cancer runs in my family, right? So until you recognize the possibility of terminality, then I struggle sometimes with taking away hope from patients. Hence my lecture on how to integrate hope into the conversation, even when it looks bleak. So I start by questioning my own biases. But, you know, for other healthcare providers, you know, I often say, before you open your mouth, see yourself not walking this patient's mile in their shoe, but walking their mile barefooted.
Dr. Anderson is a much nicer person than I am. I can tell you, much nicer by far, all right? So my answer to this is educate and then punish, all right? Because if we go back to the age, because, you know, I'm so old that I remember there was 15% women in medicine.
Right.
And the amount of abuse we took from those men, rape attempts, beatings, all kind of stuff in the workplace, from which I have been subject to all of that. And the only way those men stopped that behavior was by punishment. That was the only way. They're going to lose their jobs, and that's the only way they stop that behavior. Whoever's in the dominant position is only going to treat the subordinate person, in their minds, whoever's subordinate, by force, all right? So we try to educate and then punish.
Well, I would say, yes, that's a wow. I would say that just like body cams and cell phones have revolutionized how people are treated and what gets recorded in the healthcare system, I think it's the same thing. So, you know, one of the things that happens to me in my environment is when I'm speaking with the residents and we're calling to the emergency room, I want to hear what they're saying. So I let them know. I say, hey, you're on speaker. I'm talking to the residents and you're on speaker. Now I'm listening to what the other person says. So I get this phone call and they say, oh, I have this patient here. She's a prisoner. She came from the jail and she's complaining of pain. I really don't believe her. But you know what? Actually, she's actually quite intelligent. So I think I'm going to put her over here and can you guys come see her? And we're like, did she just say that? Did she just say that she's surprised that the prisoner is intelligent? So, you know, we called her on that bias. We said, no, she needs to have a CAT scan. She needs to have everything else that anyone else would need. And by the way, have you heard of white-collar criminals? So I think that, like, just being in a public place, having more people on the team, we now do some team training where we go in the patient's room all together. And so we're all hearing the same thing. And you know what? Different people on the team can check other people on the team. And I think that's one way to at least bring these biases forward, call it out, and then, to Dr. Roche's point, have a consequence.
We all have,
it's interesting
yeah.
because the systems, you know, and I'm trying to be political, right? You recognize the gender makeup on the stage. And by the way, both of these ladies know my parents and have been very influential in my
Oh,
upbringing.
wonderful. I love that. I love
much
that.
respect, okay? But the truth of the matter is, you know, to your point, you know, that's why we need generals and colonels and foot soldiers. You know, the systems have built-in training, right? We have quote-unquote systemic training with respect to biases, whether it's gender, religion, or otherwise. And we check off all the boxes and you get a stamp of approval, you've been trained. But having the certification doesn't translate into practice, right? And in order to translate that into practice, you need to have accountability. And, you know, that's what my general and my colonels are expressing.
Okay.
Speakerphone.
There you go. All right. Well, data shows that in New Jersey, and this question is for all the panelists or one of you who wants to answer this, that 21 to 25-year-olds have a significantly lower screening rate for a variety of things, right? You name it, than older groups. What targeted efforts are being made or should be made to actually address this gap? And why do you think this is? Why do you think this is anyway?
You know, I think when TV entered our living room, you know, the goal was to bring the world to us, right? But now that we have these handheld devices that does the same thing that TV does, you know, we were hoping.
Dr. Google, Dr. Chat GPT.
Exactly.
Okay, I got you.
The access to information is there, right? But it doesn't mean that it's accepting, and it doesn't mean that it's being practiced, right? And so oftentimes that's the disconnect with how we practice medicine. Given information, having the clientele, but the two shall not come together, right? So I think, you know, a lot of the younger generation kind of live their lives kind of what I call virtual facts, right? The facts are there, and because we see it, we think they're engaged, and they're not.
No, because they're watching Google and TikTok. I had a patient last week, and I said, you know, what are you afraid of? She said, the epidural. I said, why? She said, because Google says it's going to make you, or TikTok says it's going to make you paralyzed. Wow. Well, you know, that's actually not true. Right. And some influencer on TikTok said that. And so I think we're talking about that generation, that age range
that's
that you
dangerous.
just gave. Though that age range is getting a lot of their information. They're not even watching TV. Right. They're not even watching Netflix. They're not even watching the news. Right. They are getting a lot of their information from TikTok, Instagram, and Google, and it's misinformation. Right. So medical organizations are trying to address this. How do we get correct medical information to this group and then have them access care? I think it's really important for anyone that is dealing with this age demographic to make them understand that all that you see on TikTok and all that you see on Instagram is not true. And you should go seek medical attention if you really have a problem.
Well, I think it's even more profound than that. That's all maybe well true, but these people in this age group have a terrible problem with insurance. If you're not on your mother's and father's insurance till age 26, you're going to be in trouble in terms of insurance or no insurance. Because once you get in that age group, what they're doing with these young people is they will not give them full-time work, and they're doing gig work, and they have no insurance. Let me repeat, they do not have insurance. They also have a problem with making enough money for housing, food, etc. And health care, and they're young and healthy, is not important to them. They're trying to survive. And they're having a very, very difficult time now. And it's not just 21 to 25, it's that whole youth group all the way up to 40, the underinsurance problem is a significant issue. They hire them and give them just enough hours that they're not full-time employees, and they're uninsured. And now that they've lost their, and now that so-called Obamacare, now that they have increased the rates, it's just completely unaffordable for young people in this age group to have any insurance. Now, the FQHC is a place they might go, and they might be able to get sliding scale. Planned Parenthood is now under attack, and they're having problem keeping their funding up. It is a very, very difficult healthcare landscape for young people who are not on their parents' insurance.
Very good
But
point.
this is speaking truth to power, right? But it's also a double-edged sword. So while we want to integrate all this technology into, you know, our lifestyle to quote unquote make things more efficient and streamlined, it also sacrifices resources to these young people. They're like she said, they employ them just enough because technology takes over part of what they would be employed to do, right?
Yeah, exactly.
How many cashiers you used to see in the supermarket 10 years ago versus now, you know, and then
self-checkout is taken over.
Folks used to walk around with pads to do inventory. You don't need to do that now. You know what's in there. As one gets subtracted, so you know, the technology is also creating an issue that keeps them out of the workforce, keeps them out of acquiring the resources they need to improve their lifestyle.
Then healthcare systems are under attack as well. So there's H.R. 1, the big beautiful bill, is going to significantly affect those who are covered by Medicaid insurance. And so healthcare organizations like Newark Community Health Center. Even in New Jersey, there are places that are like maternity deserts. There's no OB providers in 2 counties in New Jersey. So it's really important that this demographic of young people know where they can go to, whether it's community health centers, the Department of Health, Planned Parenthood, other places that are available, because a private doctor's not taking them if they don't have insurance.
And, that's one thing about the FQHC is they have generally marketed themselves to, urban, inner city, a lot of people who are, undocumented. This is a marketing tool for you, is to go after these young people who are underinsured or uninsured, who otherwise might not even think of using the FQHC, and they can get health care on a sliding scale from you all right?
All right. This last question, let's be completely honest. Where is the system failing women the most to stay connected to their care overall, right? And what's the one change that could actually fix, or there might be several in your minds? In other words, you get one move to make the system work. What are you changing when it comes to women? You're thinking, you're contemplating.
I can answer this right away. Vote, 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 vote. Do not vote for anybody who does not have your health care interest in mind. And we all know who those people are. And it starts at the local level. You got to go to the city council. You got to go to the mayor. You can go to the school system, and even when those people are trying to be on the school board, what are they going to do for health care, for youth? If these people don't have a health care mindset and they're not going to help people, especially these vulnerable youth and other vulnerable groups, then do not give them your vote. They have the money. They control the money.
So I see it like building a wall, right? The rebar in the wall is what you just mentioned, right? That's the strength of the wall. We got to have policies that support change, right? But I think, just to put it lightly, I can't recall the last time a guy who has a knee on his neck asked for his father.
Right.
Always asked for his mama. So until we recognize that our society goes nowhere without our women, then those policies don't even come to the floor for discussion, right? When we take away reproductive rights, when we influence education, when we talk about DEI based on gender, once we get all this nonsense out of society and promote the value of the individuals in society, and I will first go to my mama before I go to my dad, even though my dad was a great guy, my best friend. But whenever I'm in trouble, I rarely ask for my father. I always ask for mama.
Interesting.
Okay?
Yeah.
So culturally, society needs to change, right? We need to see the value of our mothers, our grandmothers, our daughters, our sister friends, however you label it.
Yeah. It's interesting. I just read an article where they said, 99.999% of the time, the last words that people call out to is for their mother, whether you're in battle or in the hospital bed, and you can be 80 years old and still call for your mama and say, Mama, I'm coming home, whatever it is. So it's interesting that you said that, because I just read about that this week. It's powerful. It's powerful. Go ahead.
Yeah, that's true. So, I think it's about where is leadership, and maybe that has to do with voting. But if you don't have diversity and leadership that is creating that diversity, you're not going to change anything. Recently, I was at a meeting, and many of the trainees, residents that I trained over the years, came up to me, and they wanted to take pictures. And I looked around at the pictures, and there was a black woman, a Caribbean person of Caribbean origin, a Haitian woman, a Latina woman, incredibly diverse. And then fast forward now to most of the recent trainees, we don't have that diversity. Maybe we're getting it back, but we don't have that diversity. If you don't have diversity in leadership, then you don't have change, and then you have bias, and then you have discrimination. You need a diverse workforce. Every organization needs to have diversity, because diversity is where you get diversity of thought, diversity of ideas, different culture, different religions, and then you get tolerance. So diversity in leadership is really important, and it's the leaders that create that culture. So whatever one can do to get that, like-minded people, whether it's voting, sitting at the table, being at the table, advocating, if in your organization, advocating for others who look like you or who are different, that's where you get the change.
And on that note, thank you all so much this afternoon. We appreciate our clinical panelists. Do we have time for any questions from the audience this afternoon? We do. Okay, great. Okay, in the blue, right back there, wait for the microphone and tell us your name and your question.
Hi, my name is Nisala Rana. Thank you all. This is a question for anyone on the panel, but I was wondering if you could speak to challenges you face in your practice regarding cultural and religious barrier or beliefs and practices related to women's health, sexual and reproductive health. One example I'm thinking of is hesitancy regarding HPV vaccination. Like, a lot of parents believe that vaccinating early will promote early sexual behavior. So I was wondering what strategies you've used that have been successful to address those. Thank you.
So when it comes to vaccination, I use historical perspective, right? I often say that one of the reasons we don't have smallpox is because it's eradicated. And then the other strategy I use is oftentimes we need to see certain disease for what they are. You mentioned HPV vaccine. Cervical cancer is a sexually transmitted infection, right? It's an infection that leads to a pre-invasive condition that can be treated. But more importantly, it's one thing to be able to treat something, it's another issue to be able to prevent it, right? And it has nothing to do with sexual activity or promiscuity. The other thing I said to folks is just remember, whether it's a young man or a young woman, they oftentimes encounter, unwelcome advances, okay? So the best thing you can do for them is give them the tools to deal with it. All right, and vaccines are just one such tool.
One thing that we're doing in our practice is after pregnancy, postpartum, we're doing catch-up immunizations on many vaccines that are necessary in the community. So that includes measles, as you heard about it. I can't talk about hantavirus, but don't come to us. But we're catching up on HPV, hepatitis B, varicella, and measles. And so after the mom has the baby, we tell her, I say, now we're going to focus on you. I noticed that you're missing these immunizations. Would you like to have them? And we do that in the hospital. And oftentimes we get a favorable response. There are those that are vaccine hesitant, and then they're hesitant typically about all the vaccines. It's not just HPV. They just don't want anything. They don't care if they get measles. But we do that counseling during the pregnancy and then postpartum. And it's a really robust way of immunizing a community that's often under-immunized.
And I think that outreach to the community is a really great way to do it. We do these health fairs and go out and we really try to do everything we can to try to educate. And catch-up is important. I run a Colpo clinic, and all the women are there, of course, they're there because they're HPV infected. So we finish vaccinating them, and then we ask them to vaccinate their children. Do you want your daughter or son to have to go through this? No. And ask them to spread the word throughout their network about the importance of these kind of vaccines. So you can always use the people who are affected, ask them to go out, and they're your first wave of community outreach. And then we have an obligation to go out into the community and answer these type of questions and try to promote.
I often say you need to meet people where they are, right? And, there are places that people congregate, almost by second nature. Churches, the beauty salon, the barbershop. A buddy of mine had a barbershop. He had a gym. He had 3 shops, and at each shop, he has a gym in the basement. And he would invite the young guys in. Go work out. It's good for you. So you meet people where they are. Community outreach, right?
Any other questions? Right here.
Hey, my name is Chris. I think Dr. Roche brought up the subject of genetic testing. So in this case, obviously, I think the last thing we want to do is forget about, the legacy of Henrietta Lacks, right? So we don't want to forget about that, but we also want to still get whoever needs to get screened. So how do you manage that in terms of, not sweeping anything under the rug, but still addressing it for what it is, but still getting the clinical care that's needed to get done?
Good question.
Well, I think the question really boils down to suspicion of the healthcare system based on some of the abuses that the healthcare system has done to vulnerable populations in the past. And it does require a certain amount of reassurance because anybody who knows about Henrietta Lacks knows they took a cells and used it. They finally got their money, though, the family. They finally won. They're suing them one by one, and they're starting to win and get some resources back into the family. But it's the difference between, genetic testing to try to, find illness and to treat is different from that. And you really have to, talk about people's suspicions about the healthcare system, acknowledge what has happened in the past, and then give reassurance about why the testing is being done and the limitations in terms of what we place around how that information can be used. And this is where having healthcare providers who look more like the people they're counseling gives you an added advantage in terms of trying to overcome some of those barriers. But that's becoming increasingly difficult, as Dr. Gittens alluded to. I went to medical school in 1976, and there were 520 black men in medical school in the nation. How many you think there are in the first year class now? 560, with huge expansion in the seats in medical school. So we're losing ground. We're not gaining ground. So this is part of an attack on minority people from the top, because a good way to kill us off is to make sure that we do not have adequate health care, and especially for black men. It's very clear that a black man who has a black male physician is more likely to comply, be adherent, and resolve his medical problems than not. And this is a organized and systematic attack against the community, this failure to have providers who are from the community.
Another part of it's so multifactorial, right? Because another part for me, again, these two ladies were very influential in my upbringing because they were mentors, right? And then when you talk about the number of black men in medical school, the dean of our medical school, he was one of my mentors, right? And I make joke with Dr. Bay that I used to look at his graduating class and try to figure out where my portrait was going to be on the wall. Except there was a column I didn't account for, so mine didn't make it, right? Those mentorship programs, those mentoring ideas, they're becoming diluted. So to get young guys and young ladies into medicine that looks like their community, that's becoming a challenge because the mentorship and is just not there.
All right, any other questions? Okay.
I'll stand up.
Yes, please.
It's a little group. Couple of comments. Number one, thank you for mentioning genetics, because I was going to bring up genetics. Are we asking about family history, generational health enough so that we can get in early enough to make change? We're bringing a project to Newark called the All Hearts Collaborative, looking for genetic heart muscle diseases, HCM, amyloidosis, and more. If we have this opportunity through the birthing gateway, through the hospice gateway, we have a conversation with families. What runs in your family? Is it cancer? Is it heart disease? What kind is it? If we can identify the families are at risk, we can get there further. And if they have thick heart muscle disorders, we actually have free genetic testing available for them now. But you guys don't know that, and I don't know how to get that resource into your hands so that we can make it useful. And secondly, completely different topic, my organization has 62 recognized centers of excellence around the country. And what we did about 4 or 5 years ago, we noticed that the staff did not represent the community it served. So as part of our application process now, we asked for a racial breakdown of the catchment area and the staff, and then we say, why doesn't it match? And we hold power responsible for making sure that the care providers match their community, because we know we get better outcomes.
Yeah, so what we're talking about is what we've talked about in a lot, and parallels are important, but those conversations, similar to your organization, those conversations have happened in education, in law enforcement, and in community service, right? Do the policemen who service Newark look like the people in Newark? How many of them live in the community? And how does that influence police-community relationship? So again, you know, it's complex, but some of those is the same concept.
Yeah, I applaud you for the work that you've done to diversify and make your workforce look like the community that it serves. In answer to your question about how do you get that information out there, I think that for me, doing prenatal care and preconception care and interconception care, we know that heart disease is a leading cause of maternal death. So we're really focused on that during the pregnancy and postpartum. I think that having more information, the right questions to ask, I'd love to get information from you. We ask those questions, and then we can make the appropriate referral. But if we don't know to ask those questions and they're not asked appropriately, we can't delve into that history. But it is extremely important, so thank you for bringing that to our attention.
And I think from an informatics perspective, how does institutions collaborate with industry? How does institution collaborate with industry to integrate those concepts into our EMRs, our electronic medical records? Because all of these concepts should populate in a patient storyboard every time you open a chart.
I will say that we have gotten into your clinic in ways that you might not know.
Mm-hmm.
Back in 2015, the well-child examination in the state of New Jersey started to ask about family heart health history, including specifically hypertrophic cardiomyopathy. You're welcome, I did that. And we're trying to do it in every other state now. And it's slow. They want to do the athletes. They don't want to do the non-athletes, but it's more common for a non-athlete to die than an athlete. So we've gotten it in that part of healthcare, in the well-child exam, if they go to the well-child exam, and if they have that conversation. So we're trying to get those conversation starters out there, and any other ideas anybody has, we're listening.
Wonderful. It starts in rooms like this. It really does. So this is why something like this Women's Symposium is so important, and we do appreciate all of you being here once again. Please, a round of applause for our clinical panelists this afternoon. Dr. Clark, come back up. Yes, thank you so much. You're standing up for them. Thank you so much. She wants to take a picture with us, so let's do that.
Yeah, we are going to take a picture, but as you can see, we have the Assistant Commissioner of Health who's right here, and he came to work, and he is working, and so we made you work today. So could you join this panel here? Because yes, and give him a round of applause for what he has been doing for us here. Other duties are assigned. Thank you very much. All right. So, yes, thank you so much. Thank you, thank you, thank you. Which microphone? Hello, hello. All right. It was an awesome day, wasn't it? We learned a lot. We shared a lot. And we want to be thankful for the people who are on the panel and all the information they gave us today. I think it was outstanding. I think you have gotten enough information for you to start to implement in your own lives, right? And right? Yes. Rest and radiant. So we taught you today all the information you need because they said you need knowledge, right? So they gave you the knowledge. So that is going to make you what? Rested and radiant. And we taught you how to make tea. What was the whole purpose of teaching how to make tea? First, you take the time to think about yourself and decide what is good for you. And you decide you're going to have some tea. You made an effort to go to the store to buy the tea. You don't have to buy the most expensive tea. And you come home and you put on some water. It's free. I know we have to pay more for water, but it's basically free. All right? And you make that water very hot. Then you take out your best china. Did you see what we just taught you here? Take out your best china and you put it on the table, right? You make sure the children are cared for and they are resting, right? And you're going to sit there and looking at your best china, you're going to go through all of what we just showed you. Take the tea, put in the container, pour the water carefully. And as you pour, you look at the water and you smell that fragrance, right? Rest and radiant, people, rest and radiant. And when you finish pouring, you lean back on your chair, right? You pick up that cup. And when you take a sip, do you begin to feel the radiance? Do you begin to feel that all the things that you've been thinking about and all the troubles in the world, right, begin to go up like the steam. And as you go up like the steam, you relax and you think about all the good things that you have, all the wonderful things that you have achieved, and how great you are. And then you say to yourself, you need to go to the doctor so he will give you a prescription of good health, right? So I expect to see you going to your doctor and you get that prescription of good health, right? And you're going to repeat the process every evening. Can you do that? Can you do that? Yes. Awesome. Isn't it amazing? NCHC is great. Our collaboration with all our partners are great. We couldn't do it without you. Our staff is magnificent. Give them a round of applause. There they are. They are magnificent. Look at them. Look at them. They've done an awesome job. And happy 10th anniversary. Thank you for saying that. Very important. Very important. But it would not be possible without all of you. All of you. So please remember, rest and radiant. Right? Have a cup of tea. Have a great day. Thank you so much. Thank you.